Hey guys, I just wanted to say we have 5 minutes before our next session begins, or our first session for today begins. Okay, so please grab your food items and try to find a table to sit at. Good morning, everybody. Hi. For those of you that are still outside, we're going to start now. Join us soon. So this morning, I wanted to introduce Dr. Vincent Lou, the Chief Data Officer of the Permanente Medical Group, Kaiser Permanente. He's also a pulmonary critical care physician at the KP Santa Clara Medical Center and a senior research scientist at KP Division of Research. He leads programs in using advanced analytics, data science, and responsible AI to improve care delivery and outcomes for over 4.5 million members of the KP system in Northern California. He has authored over 200 publications and is an expert in the use of complex EHR data and health system evaluation in acute care and sepsis. He has served as an expert panelist in AI and sepsis research for the NIH, NAM, NQF, and NCQA. So please welcome Dr. Vincent Lou to give us the first talk for today.
Thank you so much. Can you guys hear me okay? All right, well, it's been a pleasure being here. Thanks to the program organizers and our Mayo Clinic host for giving me this invitation to participate. And it's been amazing to be an audience member to hear about the technical and computation advances that we're seeing that many of you here are leading. For the purpose of this talk, I'm actually gonna stay away from that technical layer and pull up to a much higher layer. Really to talk to this room of leaders and future leaders about how we need to be thinking about AI for value rather than volume-based care. So actually, I dug through my archives yesterday and looked at the last talk I'd given for MLHC, which was in 2021. And I told the story of how I picked up a Tesla, which I'd never driven before, with the intention of driving it from Seattle back to my home in San Jose, unbroken and by myself. And this was an interesting trip. And I relayed the story of how the Tesla nearly killed me and then later saved me as an object lesson for what we needed in our health system, but for even beyond that in terms of capabilities for engaging with AI. And at that time, talking about focusing on end user training and engagement, the importance of computer-human handoffs, for example, for the first time learning how to engage autopilot without knowing how to disengage it, and suddenly being in a car hurtling forward at 75 miles an hour with no idea how to take control. And of course, clinician and workforce agency, ultimately something that's going to be more and more important as the computational advances accelerate. How do we know and give our workforce, our end users, the agency to make sure that the AI is aligned with our intentions? And then adapting to changing workflows. Ultimately, the drive back was much longer than I had anticipated because I didn't realize I would have to stop every 2 hours or so and charge for an hour. But you know, that kind of technology leads to both intended and unintended consequences. For the purposes of this talk, you know, I think of Tesla kind of as a point solution. It's something that it's a car that a person can choose to drive, and maybe it solves some of their problems through performance and luxury and over-the-air updates, but it comes at a trade-off, you know, and there are some externalities. But really, if we're thinking about Tesla, for example, as changing mobility, changing transportation, we have to get beyond a single car, right? Because even if we replaced all the cars in the Bay Area with Teslas, you know, we wouldn't solve traffic jams. But we have to think about the entire network, the whole system. And that's where we're going to get the opportunity, I think, to really reshape and create new value out of these types of technologies. So I've probably taken that metaphor too far, but you know, that'll be kind of the direction that I'm headed. So why does value rather than volume matter? And in some industries or service areas, this would be absurd to even think of. If we paid newspaper writers by the word instead of by the article, you'd get grotesquely long articles that would actually impair our ability to engage with the subject. Of course, the best writers tend to be the most concise. If you paid a restaurant for the number of ingredients rather than for the value of the meal, the same thing would happen. So obviously it makes sense that in those cases we're trying to achieve one objective. The volume of materials produced to get there is somewhat irrelevant. There's some other service areas where there's some back and forth sometimes about whether you're really getting value or whether you're being charged for volume. Maybe that's interactions with the legal industry, your car mechanic, or if any of you have gone through home renovation or home construction, you know that when there's a question about whether that the service provider is charging you for volume or value, there can be a tremendous breakdown in trust. It can engender mistrust and distrust. And that's a little bit of where we are in healthcare today. We've seen that there's, recently, events like the killing of the United Healthcare executive, as well as other things in which the system, because it's designed around fee-for-service, it's designed around volume-based care, is engendering mistrust and distrust among all of us as patients. Beyond that, it's also causing an unsustainable, untenable situation for healthcare in the country. And I'm mostly focused on the US today. I think similar themes are playing out around the world. This is a chart from the OECD, where on the x-axis, it measures health expenditures for a population. On the y-axis, it measures life expectancy. The United States is obviously an outlier right here, significantly, in terms of the amount that it pays for the value that it gets. Not only that, 2/3 of bankruptcies in this country are attributable to medical bankruptcy, with 1 in 10 people in the country owing at least $250 in medical debt, some significantly more. And the problem is far worse in some parts of the country, like the South, where it may be as much as 1 in 5 people have medical debt. And together, in aggregate, that accounts for hundreds of billions of dollars. So the system, as it's currently designed, it's not the fault of any individual physician or nurse or health system or insurer, but it's just the way that it's been put together, again, to focus on volume. And what it's produced is a system that drives up costs through excessive and unnecessary visits, tests, services, and other types of procedures. It also produces poor quality because the way that individuals are cared for is often very, very siloed, and so there's a lack of communication and coordination in care. And then finally, poor care experience. Again, that's arising from the lack of coordination, but also the mistrust and distrust and the perception of uncertain value in the healthcare that many patients are receiving. So what does value-based care look like? And this is kind of the quintuple aim, it's now called, which is kind of thought of as the North Star of value-based care. So Don Berwick and others in 2007 kind of coined the triple aim, which is that this is healthcare that both improves the patient experience, produces better outcomes, and lower costs. That was supplemented in 2014 to say that we also want a sustainable clinician workforce and to improve clinician well-being. And then finally, the quintuple aim, which is health equity. And important here is that these items are not coming at the cost of one versus the other. So not increasing costs to achieve better patient experience or better outcomes, for example, but an ideal system in which we can both achieve better outcomes in patient experience while also lowering costs. Now, I think if you in this room are not thinking with this as part of the motivation of how you develop AI and deploy AI, it's very likely that the healthcare AI ecosystem will simply follow the industry as it's designed. We'll take a broken, siloed system, we will bolt on a bunch of AI. It will be very, very costly in the short and medium term, and drive us to an even more perilous state when it comes to the fraction of the US GDP that's attributable to healthcare, and that's currently about 20%. Because we know that there's huge amounts of investments being made in AI, and this chart is probably underrepresentation of where we are today. And of course, there are just so many vendors that are out there across many, many domains. I think people probably in your institution, certainly in mine, are worried about death by 1,000-point solutions. Just the concept that we're taking all of this stuff and then we're putting all of these point solutions, different technical platforms, and we're kind of exacerbating a problem that we have been struggling with. Okay. So what are some of the steps we can take to use AI to promote value-based care? Well, there's some that are really popular that are being touted. This is from Dr. Oz, who's now the head of CMS. This is a Wired article which said, during the meeting, Oz discussed prioritizing AI avatars over frontline healthcare workers. Oz claimed that if a patient went to a doctor for diabetes diagnosis, it would be $100 an hour, while if they went to an AI avatar, would cost considerably less, just $2 an hour. So there's many who have been calling for a long time just to simply get rid of doctors. Elon Musk, I think this was last week, tweeted, AI is already better than most doctors, that's the honest truth, and it will become far better. Although he did caveat by saying, same for all jobs, to be honest, including mine. So it wasn't just the doctors. Bill Gates on Jimmy Fallon said, the error we've come to is that computing was expensive and it basically became free. The error that we're coming to is that intelligence is rare, a great doctor, a great teacher. And with AI over the next decade, that will become free and commonplace. Mustafa Suleyman, who's the co-founder of DeepMind, said, AI will only temporarily augment human intelligence. The tools will make us smarter and more efficient for a time, but they are fundamentally labor replacing. In the face of an abundance of ultra-low cost equivalents, the days of cognitive manual labor are numbered, and we are only now just starting to see what this new wave is about to have. And he was talking about all different types of cognitive workers. Of course, famously, Jeffrey Hinton in 2016 said within 5 years, deep learning is going to be better than a radiologist. That got a lot of press. And even going further back, Vinod Khosla said, I was asked what I was doing about other large societal problems, namely healthcare and education. I flippantly responded that the best solutions were to get rid of doctors and teachers and let your computers do the work 24/7 and with consistent quality. And he talks about how that could be possible even in 2012. The beginnings of Dr. A algorithm will be much criticized, but Dr. A will get better and better from providing bionic assistance to second opinions, to first opinions, to the best 20% of human breed doctors, and who knows what will happen beyond that. But the story actually goes even further back, and this is the landscape of human competence, which was proposed by Hans Moravec in 1997, a roboticist. And I'll take you through this. There are kind of like 3 different parts of human competence terrain. There's the low-lying areas in which there's kind of tasks that can easily be overtaken by computation. So that might be arithmetic, that might be rote memorization, vision, speech recognition, chess. And then there are like the low foothills in which the computation would be more difficult. Winograd test has to do with interpreting text, social interaction, management, and then this kind of mountainous areas or the peaks where it would take a long time or these are the kind of like the pinnacles of what we think of as human competence: science, book writing, art, cinematography, etc. I just shoved medicine in here as the blend between science and art. But what he said was in 1997, so this is less than 20 years ago, advanced computer performance is like water slowly flooding the landscape. We feel safe on our peaks, but at the present rate, those two will be submerged within another half century. And I would argue that we're pretty much just the barest part of these peaks is now above water in a short amount of time. And so the march of this inevitability that we need to redesign the way that we deliver care to extract more value. Most are talking about replacing physicians or other roles with AI, and certainly we've seen that computational capability expand at an incredible pace. So how do we actually put that together and think over kind of what the future of this value-based care will look like? So I like to turn back to some of the founding tenets or principles or leadership of Kaiser Permanente. This is Dr. Maury Collin, who this is his obituary in the New York Times when he died at the age of 100. But in the 70s, he was working at Kaiser Permanente to develop one of the first computer databases to track patient health. That became the foundation of of the EHR, essentially. And by the early 1970s, with the help of federal funding, the database had grown to hold information on several million patients, becoming a valuable tool for tracking individual cases and also for identifying broad trends. He also established the field of medical informatics. He was actually both a physician as well as an electrical engineer. So I think really very much bringing those two disciplines together. But he was actually hired by the first physician of KP, and this gentleman's name is Dr. Sidney Garfield, and who put together the design of this system, which was designed around value rather than volume-based care. And again, 55 years ago in Scientific American, he said, we need an innovative system in which the sick are separated from the well. I'm going to just quickly take you through this. This is a bit of an eye chart, but I'll break it down. So essentially here at the top, what he said was that if we move from a fee-for-service model, which is when you show up to your doctor's office, you give a payment, and we move to a prepayment model, which is where we have a capitated system in which there's payments for whatever care you need to receive. One of the challenges we're going to face is that our doctors will be overwhelmed because you've removed that barrier to entry. So instead of just sicker patients showing up, anybody can show up, and that'll include patients with a diversity of case mix in terms of severity. So that would include the well, the worried well, the early sick, and the sick. In order to not be overwhelmed, we then need to set up a system in which we are appropriately and proactively moving patients to the right place in that system. And that's composed of 4 domains: health testing and referral, which would do automated history and labs, x-rays, EKG, physiologic data. That would be run by paramedical staff. And this is what I described that Maury Collin was doing. They were doing a standardized exam for every patient, collecting that on intake for millions of patients. There'd be a healthcare center. So that would handle things like education, immunization, exercise, drug and psychosocial counseling, nutrition, family planning, prenatal care. And then there would be, and importantly, he called this health care instead of what was happening a lot, which was sick care. Preventive care would address obesity, diabetes, hypertension, arthritis, back, mental health, geriatric, and rehabilitation. All of these 3 domains run by paramedical staff, and then finally that left sick care, where there would be the group practice, clinics, hospitals, special labs, radiotherapy, acute and intensive care, and extended care, and that would be run by medical staff. And so you can already see in this design that it's very much focused on not necessarily the intensity or volume of care that you're receiving, but overall working to coordinate this system. What was pretty prescient about this 55 years ago was that he also said the computer should be at the center of this entire thing. The only way that we could actually succeed would be for the computer to pull in all of these data and transition patients and do that proactively and efficiently. And so that's kind of continued to be our vision for how technology and AI can really integrate well with this system. It is not a human versus a computer battle. The computer has been part of this design since the beginning. And fundamentally, in order for us to extract value from AI, we are going to have to reshape the way that we deliver care. So kind of products that we're focused on, intake and triage, risk stratification, and early upfront diagnostic testing. Obviously, heavily interested in health education and healthy support, preventive care, chronic disease management, and wellness. And wellness is becoming a very hot topic right now. Care coordination, communication, and shared accountability. This is a major gap. So the ability to transmit information to your colleagues, to be able to work together, and to make sure that there's seamless coordination. And then finally, there's always going to be a place for the kind of domain specialization, the specific tools that any clinician needs, point solutions which are going to really accelerate the way they deliver care or generate insights. And I think one thing that was missing a little bit here, but is also really important, is for patients to also be partners here. And so, I'm thinking that the future of healthcare means investing heavily in AI applications that support this system, but that are jointly also supporting patients. So as we're thinking about rolling out internal AI systems, we should be in parallel thinking about how we can make those available to patients so they can have the same insight and be partners in this journey. Otherwise, it's going to result in a little bit of a battle. Patients will be bringing their AI, the health system will have their AI, and the AIs will probably breed mistrust or distrust. Okay, I'm going to quickly run through examples, some early examples of how we've been thinking about this and trying to execute these AI projects at scale. We were one of the first to roll out and test an early warning system in our hospitals. We call it Advanced Alert Monitor, estimated to save 500 lives per year across our Northern California 21 hospitals. This was an analysis we did over 500,000 hospitals. We took that and rolled that out to readmissions. Also, we're able to reduce readmissions by 10% with no increase in mortality, looking over 1.5 million hospital discharges. But even colleagues who developed more simple scores, like neonatal early sepsis calculators, reduced the use of blood cultures by a third and antibiotic use by half for babies in the first days of their lives with no increase in adverse outcome. So risk stratification, moving up to a population health layer, and engaging in proactive outreach. Of course, we're continuing to advance that. This is Dr. Vignesh Arasu at KP, who's looking at computer vision and breast mammography, but has already deployed a system to enhance our ability to do personalized outreach for screening. So by using hidden features in the mammogram along with clinical risk factors to hopefully increase our capture of women at risk for incident breast cancer. And David Oyang at KP, who's been working on using beat-by-beat measurement from echocardiogram in order to detect not only heart disease, but also diseases throughout the body, and to use things like vision language models in order to also accelerate the timeliness of the reading of these studies. So I know there's others in the fields working on these things, but these are some of the areas for population level screening. We deployed an NLP Gen AI system for the flood of messages that we get in KP. So this was a 5-month analysis of nearly 5 million EHR messages from patients to our primary care docs, and in adult and pediatrics. We assigned real-time NLP and LLM labels so that the messages would flow to regional virtual intake clinicians, and the use of AI paired with those workflows allowed for 1.5 million messages, or 30% of messages, to be resolved without ending up in those patient inboxes. But when we get up to that system scale, you begin to see some really interesting things. So this panel breaks out the content of those messages. For example, dark green, light green here is blood pressure related. This is asthma. This blue is medications. Orange is mental health, et cetera. And when we get up to the analysis at that level, what you realize is that on a week-by-week basis, the content of messages across this very large population is extremely well preserved. And so we can think about systems which will allow us to serve these needs more effectively across the population, and of course leverage AI in that process. And then finally, you know, we were the first large deployment of ambient AI scribes. This described our experience over 2.5 million uses. I think we're now at 12 or 15 million notes. I haven't checked recently. But we, you know, of course, sustaining our workforce. So this shows the time and notes spent by clinicians who are high users, low users, and non-users here in gray, and actually showing that the use of ambient scribes with our first product actually brought our high users in line with our other users, and then with our second product actually drove even larger gains. And so these are you know, some of the ways that we're thinking about value-based care, but there's so much more to do here. I'm very excited to see all of the innovations and leadership that that you will do both in your science and in your industry in order to help us achieve this goal of value rather than volume-based care. Mustafa Suleiman, in his book, The Coming Wave, says the AI has basically already passed the Turing test. We should have a modern Turing test. And so he said that would be go make $1 million on Amazon in a few months with just a $100,000 investment, that would be a worthy achievement of new AI. And I've been trying to think about what would be a creative value-based care Turing test for us to see that we've been able to leverage this technology to achieve that goal. This feels both too ambitious and not ambitious enough. But thank you very much.
Thank you for that talk. Now I'm going to introduce Dr. Karandeep Singh. He's the Chief Health AI Officer at UC San Diego and the Joan and Irwin Jacobs Chancellor Endowed Chair and Associate Professor of Medicine and Biomedical Informatics at the University of California, San Diego. In these roles, Dr. Singh oversees AI strategy and governance for the health system and leads AI initiatives within the Jacobs Center for Health Innovation. He received his MD from University of Michigan and then completed his internal medicine residency at UCLA Medical Center, where he also served as a chief resident, and then went on to the combined Brigham and Women's and Mass General Hospital programs to do his nephrology fellowship. And he also holds a master's in biomedical informatics from Harvard Medical School. Thank you. Come on.
Mic is good? Awesome, thanks. So it's a delight to be here with you. Thanks for the warm introduction. Vinny, thanks for that great talk, kind of diving into clinical side of things and really what do we need to do clinically to really improve health outcomes. One of the things I'm actually going to talk about is focusing on the other side of delivery, which is operations, and thinking about not necessarily how we do a better job clinically in diagnosing people, but what do we need to do as a system that has worked kind of, in a way, for so long, bolted on technology, just that's accumulated so much tech debt over these years. And now we have this opportunity to really modernize our healthcare operations, and what are the sort of challenges we can solve through kind of modernizing our healthcare operations, and what does that agenda look like? So here's my one disclosure. I serve on the Consumer Health Advisory Panel for Google. And so a little bit about me. So I'm a Chief Health AI Officer in a health system. What this means to other people is that I think all problems are solvable with AI. But what this means to me is that there's a lot of actual problems that are health system problems. And what I'm tasked to do is to really think about what of those problems are actually potentially solvable with AI, and what are the different ways we need to design our systems where AI actually can lead to better outcomes. And that's no easy task, and it often means a lot of difficult change, but that's kind of the role that I have within that system. I also am fortunate to lead an AI lab within our Jacobs Center for Health Innovation, which is essentially kind of a way of having a scholarly team taking a rigorous approach to trying to measure the things that we're doing, so that as we change the system, as we think about new ways to deliver kind of care as part of the healthcare operations process, that we have a way to actually generate scholarly output and actually think about that in a critical way, which often you'll notice there's a dichotomy between the people who do research in healthcare and the people who do operational work in healthcare. And so this is kind of an effort to try to bring those two things together. While it seems less relevant, I'm also a practicing kidney doctor. And what I will say is that for folks in the room who are looking at potentially doing a career that's a blend of science and medicine, that my first week that I spent in the health system practicing as a kidney doctor at UC San Diego, I learned more about the health system in that 1 week than I had in probably the year of people describing the health system to me. So I think both the opportunities and challenges become extremely apparent when you're even just a few days in the system, and you start to see how the numbers that you were seeing on dashboards, what do those viscerally feel like when you walk down to the ER? You get kind of that connection to the system. And I think there's something about that really makes the system come to life. And so as you're thinking about tackling problems, you're thinking about it in a really applied way and in a realistic way. So not in a kind of I have a solution to sell you kind of way. My journey in healthcare operations started back when I joined the faculty at University of Michigan. I've always been interested in kind of both the innovation happening in technology, but mostly in terms of when we take that innovation and we apply it, what do we actually find? When the rubber hits the road, do things actually work? And I had the position at University of Michigan of leading AI governance and helping to establish AI governance. And one of the early things that we kind of dove into was, do we want to turn on specific models and actually use them in clinical workflows, and how? And at that time, the prevailing wisdom is that non-interruptive alerts don't actually work. So the only way that you can have an effective AI is to enable interruptive alerts. But when we actually enabled these in 1 or 2 units, we found that in those hospital units, none of our outcomes were changing. So we went back to the drawing board and said, let's ignore those 2 units, look at the rest of the hospital, and try to understand what's actually happening at the intersection of when that AI is hitting the bedside that's driving us not to have better outcomes. And that led to this work where we looked at a sepsis model deployed widely across the country, including within our electronic health record, to try to understand at University of Michigan, why is this model not working and actually achieving those kind of better outcomes when we talk to our quality committee who's trying to manage this on the operations side. So what do we find? We find that most people around the country are using this model to decide to prompt someone to start antibiotics. And yet, by the time this model fires, most people are already on antibiotics. And so that was fundamentally what was happening, that was kind of only uncovered as we thought through, what are clinicians doing with this information? How are we using it? And trying to understand, when we link model performance back to clinical activity, why this system is not working as well as it should be. This was surprising at the time, and it led to kind of a lot of press and obviously a lot of controversy around, is that actually real? Is this a reproducible finding? Is this kind of a one-off thing in this one health system? But I think that this also led to policy impacts and trying to understand the way the FDA regulates software as a medical device was tweaked as a result of finding that these AI tools don't always work the way that you expect them at a system level. And ultimately, this led to changes in White House policy. And so I think what I recognized was that the governance and the day-to-day operations work that a health system does in working with AI actually is often connected across systems. It's a shared experience, and there is clear implications not just to the individual people working within that system, but also to other ways in which the system gets put together that impact the kind of care that our patients get, and actually that translation of does implementing these tools actually lead to better outcomes, and to try to figure out how do we make sure that it does, as opposed to the current state where we often just don't know. The systems go in place and we don't know. Okay, so before I dive into healthcare operations, Vinny talked about it, but I'll just talk about it in an even simpler way. What are health systems? And I would say health systems are a way of organizing the care and resources that people need when they get sick, and the resources that we need to prevent people from getting sick. They often takes place at home. Sometimes people live in a nursing home, skilled rehab facilities, clinics, ERs, hospitals. And so health systems are essentially trying to figure out, how do I organize these resources so that the people who need them, the sick people, not the worried well, are the ones who get the resources? There's a saying in healthcare that if you know one health system, you know one health system. And so even though on paper, two systems can look the same, they have the same set of services, the way that it feels to work in those systems can be polar opposites and feel very different. And so I think that when we think about how we might use AI or how we might use technology within these systems to improve care, it is really helpful to be in the system and to understand how does that system actually work, how are the things put together, because the same set of services can be put together in a different way and lead to very different challenges that are solved in a very different approach in terms of how you bring AI into the picture. Okay, so healthcare has two components. I think Vinny talked a lot about the first one, which is how do we organize care and deliver the best possible diagnosis and treatment, and that includes AI-based triage early up front to try to make sure that we direct the resources to the patients who need them. Healthcare operations is something that often happens behind the scenes, right? It's ensuring that care is as safe and efficient as possible. It's the sort of thing that you do because you want people to get the best possible care. So if you have the best doctors or the best treatments, but it takes you 6 months to get in to see someone, you can't possibly be getting the best care. So this is kind of the kind of why it's important to think about AI when it comes to operations. It's not that unlike Amazon in some ways. There's a team at Amazon, right, that presumably works on their collaborative filtering algorithm and makes sure that when you select one item and another item, that the next couple items it shows you are the most likely items that you'd want to buy. And Amazon does a pretty good job of that. But if Amazon didn't get you the deliveries to your house on time, all of that would be a moot point. And I think that's the issue we have in healthcare. We have the ability to do amazing things, amazing things, but we don't have the operational infrastructure to actually deliver those things to you in a way that leads to better outcomes. And we've seen that from the chart that Vinny showed, where we're spending more and more money, we're seeing diminishing returns on that money. And some of that is because our operations are problematic, even though our clinical care continues to get better. So even though most of this talk will be about healthcare operations, I do want to remind folks, in case you're not in the clinical care space, that the last few years has been just an amazing time to be in healthcare. CAR T therapy has basically made incurable cancers curable. Stuff that we were taught in med school that you can't cure is stuff that you can cure now, and that's crazy to me. Just earlier this year, they were able to implant a pig kidney into someone as a kidney transplant, which would, if that worked, that would dramatically change what it means to have a shortage of transplanted organs, because you suddenly now have initially animal organs and maybe then even synthetic organs that you could put into people that would extend people's lives in a way that we can't do today. And this was only possible not just because no one ever thought to do it before, but they actually genetic edited the kidney so that it didn't immediately reject when it entered the human. So the sort of thing that the gene editing technology is enabling, new ways of delivering care that you never would have thought possible. And so when people ask me why are there so many people in the hospital, it's because we can do stuff like this. This is why people are in the hospital now, is that 5 years ago you couldn't even do much of this stuff that's on the screen today. And sickle cell disease and beta thalassemia, things that you're born with, and you're basically destined to have recurrences and have a lifetime of often painful episodes for a sickle cell crisis. These are things that now look like they may be possible to cure and get sustained remission, again, through the magic of gene editing. So just to say that clinical care is incredibly important, and these advances are the fundamental reasons why we have to now worry about how we deliver these advances to people. But I want to talk about some of the real pragmatic issues that we face and think about kind of healthcare at both the macro level, and then we'll dive into some actual case studies and real examples. So what does healthcare operations look like at a very macro level? At a macro view, you're often balancing inpatient and outpatient capacity. I remember when I was a resident at UCLA, when they were building a replacement hospital for their existing hospital, the new hospital was smaller. And the reason was, the stated reason was, is that, well, people won't need to be in the hospital in the future because we will just take care of them at home. Now, they didn't know we were gonna be able to do all this stuff to people and cure cancers that we couldn't cure, and those things require people to be in the hospital. And so now suddenly, there's this great inpatient demand that didn't exist before. Health systems are often changing. So the moment you build a new clinic, that creates new patients for you, new capacity, de-risks many health systems that are not Kaiser, because for them, they're reliant on kind of getting healthy patients on the outpatient side so that they can kind of balance the costs against the more expensive inpatients they have. But then you go ahead and you see a merger, two systems merge, and suddenly that balance gets thrown off. And now you have a lot of inpatient beds, and now you're struggling to fill those beds, and now your hospital's failing, and now you need additional outpatient capacity. And so there's this constant pendulum that's swinging between you trying to make sure you have enough clinic capacity to see people in a timely way, and that you have enough inpatient capacity to care for those people when they actually get sick. And obviously, if there are deep cuts to Medicaid and Medicare, that will fundamentally change what we're even able to do. And so a lot of people now are thinking about AI at the executive level because they see these cuts potentially coming, and they're thinking, what are aspects of our system that we could potentially use AI in that would actually save us money as kind of a driver without sacrificing care? So almost like maybe not triple aim, but like 2.5 aim of we don't want to make things worse, but we do need to save money because the system as it is not sustainable from a cost standpoint. At a micro view, what does it look like? Many systems are just individual services patched together. And that's where I was saying, you can be in two different systems that on paper look the same, and yet they feel totally different as a patient, they feel totally different as a clinician, and you often see that at the micro level when you're on service. Almost everything that we have is at capacity. I don't know where you guys are right now in your local health system. Maybe Mayo Clinic is different, but I would say almost every system around the country is operating very close to, or if not at capacity, just by virtue of the fact that there have been closures of rural hospitals, closures of smaller hospitals. So the systems that are left after all those mergers that have taken place are mega systems where every service is in high demand, and we have an aging population. And so one of the operational things this has led to is this concept of boarding. Raise your hand if you know what boarding is. Okay, so that's actually fewer people than I would have thought, which is good. Boarding is this idea in the ER that a patient comes in, needs to be admitted to the hospital, they're physically in the ER, and they're admitted now, but there's no rooms actually in the hospital upstairs, so they're getting hospital care while they're still in the ER. So in many hospitals, the ER team is not even responsible for that patient anymore. Someone else is. In some hospitals, they send a float nurse down, and others, it's still the ER nurse. So you can see how many patients we have boarding is ultimately a downstream common kind of final pathway towards all kinds of other upstream problems that system is facing at that moment. And it's a very common problem, and it's a problem that very likely you're going to see more press on in the coming year or two as people start to try to measure this across systems and to quantify it, because it is likely something that's a cause of bad experience and a cause of bad patient outcomes. So is boarding fixable? Interestingly, right before the COVID pandemic, health systems were struggling with boarding as well. I remember I was at University of Michigan, and we were getting emails every day, please discharge your patients early in the morning, as soon as you can. because we have a round of patients just waiting for those beds in the ER, and the faster you get people out, the faster we can get people in. And I always found that a little bit laughable, because I'm like, if I could have gotten them out, I would have gotten them out. We're working as hard as we can for individual patients, and yet that's the closest proximal thing that I can do that would fix the boarding problem, recognizing that there's a whole upstream set of pathways that creates the problem in the first place. But during COVID, we fixed the problem. So this is actually a plot from aggregating data from 24 US hospitals during COVID that we had done an analysis on. And while those little lines represent sepsis alerting patterns across those 24 hospitals, the gray shaded area in the background actually is the hospital census across those 24 US hospitals in aggregate. So the numbers are on the right in terms of the number of patients that represents. And you'll notice that when the first COVID case hit each of those 24 hospitals, in the 1 to 2 weeks afterwards, the hospital census dropped. It didn't go up. And this led to a lot of conspiracy theories around the hospital's empty, what's going on. Notice that sepsis alerting actually went up because everyone came with fever, everyone had high heart rate, everyone looked like they were septic. But the census went down, and the reason it went down is that health systems actually tried to prepare for COVID. They canceled elective surgeries. They told people, if you are here for some other reason and you don't need to be in the hospital, stay at home. We'll do everything we can at home because we don't want you to come to the hospital, get COVID, and then have an even worse outcome as a result of that. So it's a fixable problem, but it required operational changes. No amount of IT and AI created this. It was actually health systems choosing to cancel surgeries, lose millions of dollars, and that ultimately led to a bunch of layoffs that actually enable that capacity, so that had we actually peaked at COVID in a way that many health systems were expecting, we would have been way over capacity, and that was the only way to create that capacity, was to go ahead and cancel surgeries. This is not something health systems are really capable of doing today in this level of way, because this was catastrophic in terms of financial impacts across the country, at least at systems that aren't fully on value-based care. All right, so where are opportunities in that boarding problem where we may be able to use AI to actually tackle it? The first one I'll highlight is measurement. Think of all the places we do chart review. We do chart review to measure quality. We do chart review to look up a set of patients and understand what actually happened when they had a bad experience of care, when there's an incident report filed. And one of the things that actually happened here is I was talking to one of our associate chief medical officers, and he said, for this boarding problem, one thing I want to understand is, are people being sent from clinic to our ER? We have 3 ERs, we have a 3 hospital system, and we have one that particularly has a high volume compared to the other 2. And so we want to understand, are people being sent to the ER from clinic, and are they disproportionately being sent to that ER? What is going on that's creating this kind of lopsided demand? And is it possible that on the outpatient side, we could direct people to a different ER and therefore kind of solve this problem and solve boarding in that one hospital, especially for patients where they don't need to be in that ER because that's our highest acuity hospital. So to do automated measurement, we created a tool called Note Reader. A lot of stuff I'll be presenting today is not yet published, but it's stuff that we're going to be published. Review tool that you can use to review individual charts, that you can use to review multiple charts. And so you can give this a list of medical record numbers that has a bunch of individual dates for each patient and ask questions. And this actually uses Llama 4 Scout to answer those questions and create a structured output. I'm not showing you real patient data, I'm showing you kind of what it looks like and blowing it up. But essentially, we took all the notes in the 24 hours before someone showed up in the ER and in the 6 hours after, because that captures some of the ER triage documentation. And we asked this question, was this patient sent from clinic? Answer yes or no. And create a variable name called sent from clinic. You can ask up to like 20 questions. This kind of in one API call allows us to answer all those questions patient by patient. We do a bunch of fire calls and we pull these actual notes in real time. We also have a database of notes that we can draw from for older notes. And the output looks something representative like this, where you essentially get a yes-no answer across all your patients. And then you can now take that, throw it into Excel, throw it into any kind of spreadsheet, throw it into R, Python, whatever your language of choice is, and actually start to understand how much of an issue is it. And so the first thing you want to do is you want to make sure it's accurate. So in the first view that we create, we show you the original text, and it's a note level analysis where you can verify, if the answer is yes or no, was it actually real and was it actually true in the notes, and tweak your prompt. And then we have a patient level analysis where we aggregate all the patient notes from that period, and we ask the question over the aggregate of the notes in that time period. So this was useful at a patient level. Our chief medical officer actually did this analysis by hand for 100 patients, and across the system arrived at an estimate of like 30% of patients who show up in our ER are sent from clinic. If it was always sent from our clinic, we wouldn't need the LLM to do this. We could actually check, but we have patients who come from other clinics, and so the only way we'll find that out actually is in the ER triage note where it says they showed up from XYZ clinic. What has this allowed us to do? This has allowed us to turn what is a simple question that required a 100-patient chart review into something that we were able to scale to run it on 1,000 patients, however many we have. We run it only on weekdays and daytime because we assume that on weekends things look different. And so we are looking at opportunities where we actually could redirect patients potentially to one of our other ERs. And we've turned this into a metric that we calculate monthly now. So when we first started tracking it, 40% of patients in one of our locations in La Jolla were showing up from clinic. Over time, that's dropped off a little bit. That's also because of the summer, and we've had some changes in our actual ER volumes. But this is the sort of thing that, had we done this before, we would have checked it once because it was a manual labor effort. We wouldn't have done it every month. But now we've been able to turn essentially a question that is a plain language question into essentially what is a metric that's fully LLM-driven. We've shown that you can do this to abstract quality measures. So our SEP1 reporting recently, we switched from fully manual to an AI-supported workflow where we actually ended up canceling a contract with a vendor that we were using that had a fully manual process to do this. And we said, well, we actually have an AI tool. And the AI tool actually reads the chart, answers all of the SEP1 bundle questionnaire questions one by one. Individually, that model is 97+% accurate on every single individual question. In aggregate, it's 90% accurate across all the questions. So if any one of these criteria is met or not met, then you don't meet the bundle. And this is just a list of there's 20 plus questions. So this is just a snippet of those. And when we were doing this analysis led by Aaron Bucina at UC San Diego, one of the interesting things we found is that when the LLM is wrong, in nearly half the cases, you go back and review the chart, and actually the person was wrong, and they missed something. So even the question of what about hallucinations or LLM mistakes, it turns out that when you actually look at something that's super tedious like this, you'll actually find instances of something that got documented that one of our human reviewers missed. And so it's not necessarily just the case that it's the LLM that's wrong when your gold standard doesn't line up with your LLM. Sometimes your gold standard is actually faulty. These next three I'll lump together: simulation, prediction, and intervention. You can't study a system and fix it if you can't simulate it and figure out how it works. And simulation can mean you actually simulate it one event at a time. Simulation can also mean, or what we do discrete event simulation with distributions and random sampling. This is actually me playing back our health system in actual real time over a 5-day period a couple months ago. So this is patients flowing in through our system, through our ER, some of them going home, some of them being inpatient and staying for a period of time. The red dots are people who are already there at the beginning of the simulation or were direct admissions through the OR or through our direct admission process. And the blue dots are people who came to the ER, and the green dots are people who got admitted after they came to the ER. So this is something that you can look at. And our ER care volume is super unpredictable. So when we try to do kind of any of these AI-based workflows, we find that this fact that our system is so unpredictable makes this very hard to fix the problem of boarding. On the same day, we might have 60 patients under the care of the ER as we have 0 patients under the care of the ER, as we have this just rapid kind of turnover of patients arriving, being discharged, and being admitted, and ending up in the care of our teams. And there's even kind of a seasonality day to day over the course of the week. So you can see here that we have weeks where things are lighter or busier at one of our hospitals, but even within each week, there's this kind of seasonality where things peak on Thursdays, things get light over the weekend, and kind of that process repeats. So if you wanted to fix boarding, another place you could do it is you could look at our scheduled OR admissions. And so, I'm showing you here that Mondays are our busiest day for the OR. This is the number of patients who show up over a several month period on Mondays outnumbers the people by many, many times the number of patients who are admitted on Friday for surgery, for example. So we thought, well, if we want to level load, can't we move some of our Monday surgeries to Friday? That might mean we have sick patients over the hospital, which is not ideal, but it's the only mathematical way to actually reduce and level load across our census across days is to be able to actually move cases around to different days than what they currently are. So what if we moved 20% of surgical admissions from Monday to Friday? Which ones would we move? We obviously can't move all of them, and we wouldn't want to necessarily randomly move. And so this is where simulation meets prediction, because ideally, you want to actually move the highest risk patients, the people with the longest length of stay. And so the next thing we did was we said, let's predict length of stay. So what happens if you predict length of stay? What you find is that Monday actually isn't the main driver of problems. Even though Monday has the most surgical admissions, if you look at the predicted bed days that Monday is accountable for, it's slightly less than Wednesday. But Friday is actually an outlier, right? Friday, we don't admit many people. Even though they're admitted to stay, they're expected to stay a little longer individually, there's just not enough people where it actually adds up to anything. So we said, let's see if we can move some of the Monday patients to Friday and what that would mean. And so this is what I mean by simulation plus prediction plus intervention. Here, we didn't actually do the intervention, but that's something that that was a next step, is to actually do this. But the idea here is take the 20% longest predicted length of stay admissions and move them from Monday to Friday, and then rerun the simulation for the system and understand what happens. So what does that actually mean? What it actually means your intervention is you're taking, even though it's only 20% of patients, because it's your longest predicted length of stay of patients, you're disproportionately moving the bed days accountable for those patients from Monday to Friday. So almost shifting half your load to Friday because the outliers are responsible for the longest lengths of stay. And so what ends up happening ultimately, this is the kind of punchline of the story, is that you actually create 3 to 4 beds of additional capacity on weekdays. That can sometimes be even less, like 1 to 2 on Wednesday. But on a Monday or Tuesday, it's like it's a couple beds of capacity that you create at the expense of losing some capacity on weekends. But you can see that this starts to now level load our system across days of the week. Unless we're going to operate on the weekends, this is the best I can do if we need to move 20% of cases around. If we move 30%, 40%, you can imagine that at a health system level, as they're thinking, do we need to open a new outpatient ambulatory surgery center? Do we need to redirect patients and get them surgery at a different hospital in the first place? This is the kind of operating system of, I think, operational AI, is to be able to do basic simulation combined with prediction and to simulate interventions so that you can actually try to understand what is the impact of actually making changes in the system. Resource constraints play an interesting role, and I think I started a couple minutes late, so I'm going to wrap up in about 5 minutes, that's okay? Yeah, okay. So on one hand, the whole reason we ran prediction is because we had a resource constraint that we couldn't just move everyone, and we didn't want to do it randomly. But interestingly, when you predict an outcome, if you don't have the actual resources to handle the result of that prediction, you also overestimate the performance of the model. So for example, if you were trying to transfer patients to the ICU, and you had a model that said 6 patients need to go to the ICU, but you only had a capacity to accommodate 3 patients, your model might be really sensitive and have a very high sensitivity, but that sensitivity is meaningless if you actually can't send those patients actually to where they need to go. So your realized performance for these models is often different, and so the resource constraints is a two-way deal. On one hand, it actually impacts how you do the simulation through the role of prediction. On the other hand, it also impacts your performance measures when you're trying to measure this and simulate this in advance of actually implementing it in the system. I'll skip over this. This was just a package we wrote to actually do some of the simulation of resource constraints within a system. I'll skip some of this stuff around forecasting at the system level and some of the stuff that we've done. And I'll kind of close with some of the thoughts around, can we build predictive AI faster? The way that we often build tools or build AI models and systems look like this. You have 3 use cases, so you separately convene 3 sets of stakeholders. You figure out what data you need to run for each of these different models, and you spend 80% of your time on that step and only really 20% of your time actually building the model. This does not scale, because for every different problem that you're trying to solve, you're disproportionately spending all your time aligning stakeholders and not on actually building models. NYU-Tron actually showed us there was a better way to do this, except it's extremely expensive. They fully trained an LLM on their electronic health record, and they supervised, fine-tuned it for several outcomes, and found that it performed better than the equivalent structured model. But even if it performed the same, I would say what they saved here is they didn't have to align a bunch of stakeholders. They could just supervise, fine-tune it, and they would be able to kind of do this. And so one of the things that we're doing, actually, is taking this concept and making it scalable and cheap. And that is this idea of note casting, which is inverting the thinking around how we do predictive AI. So rather than saying you take unstructured data, convert it to structured, and then build your XGBoost model, we flip it around. We say, I ask people, is the information you want to know that would inform the risk of this patient, is it in the notes? And if the answer is yes, we're done. You go home, we'll talk. I might ask you, what information do you want us to not consider about this patient? Do you want us to not consider race? We can do certain things that actually deal with bias. But the key thing is, once they tell me they look at notes, for non-real-time models, most of the models that we use in operations are not real-time models, we can then start with a set of shared embeddings that are trained directly off of patient notes. And we spend almost all of our time just building the model, which is not very much time at all. And so we can build dozens of models, because each model, all I need to know from someone is the variable that contains the timestamp. And everything else ahead of that is starting with the notes through an LLM pipeline into shared embeddings. And then those models are just trained directly off those embeddings. This is our process that we're applying to do this. The goal here is to predict every operational outcome for every patient every day. So you can even have one model that does all this with multiple heads, or you can have separate models. But the point is, this is substantially faster. And that big box, that step, you only carry out once a day across the entire system. The only thing that you need to do when you get a new outcome is to train your model. And once you've got that, this pipeline just kind of works, and you can just apply it every day on patients. And so this is something that we've now started to operationalize within our system, in which we're looking at multiple outcomes to do this, such as predicted day of discharge and things that we need to use to drive actual operational decisions in our mission control. We can beat structured model performance with this tool. It frankly doesn't matter if we couldn't beat it. If we can get roughly the same performance, it's worth it. That 80% time is so expensive that we just don't have the ability to scale it. And so that's where all the time savings are. So even if these were all equal, this is worth the actual effort to do this at a system level. The last comment I'll make before I close is just around automation, which is that chart review is incredibly time-consuming and expensive. This paper out of, I think, Hopkins showed that for a set of quality measures they looked at, every single measure individually cost $33,000 a year, and that's just per metric. And so that is not a scalable thing. When someone says, hey, I want to look at how well the ER is doing in terms of where the patients are coming from, I can't think, well, is that worth $34,000 a year to know? Because that does not scale, and that disincentivizes you from actually collecting data and trying to measure quality, and we don't do a good job of it. And there's this great quote that, financial cost aside, if good care is the goal, the greatest cost of all this quality measurement may be wasted time. These hours could be spent in countless other ways. Caring for patients raises the obvious question, is the system we created to fix the system even working? So I think I'll close with this thought that like Vinny was saying, you can't just take AI and bolt it onto a system and expect it to work. You have to redesign the system. And what LLMs and AI is doing is creating the possibility of us building entirely new workflows. Like imagine a system where an incident report happens because of a safety event. Everything up until the corrective plan is developed is all done through LLMs in concert with documents from your system that describe the system for you. And it's not till the very end that a quality specialist looks at that and says, yeah, that's a great corrective plan, or no, that's not going to work. Because right now, we spend all the time measuring that we spend almost none of our time fixing. So where can AI support operations? I shared some of these examples of measurement, simulation, prediction, intervention, and automation. What it takes to get there is really clear operational goals, a really tight connection between operations and IT, accountability, data science expertise and infrastructure, a workforce that has education and is enabled to actually do the work, and definitely you need AI governance. And I'll close with this quote that I think this is still true today. Hospitals are overwhelmed with the number of AI models available to them. And to really understand and use these tools safely, we have to not prioritize problems based on whether there are tools available, but whether the problems are actually solvable in the first place. Thank you.
Thank you. Thank you, Dr. Singh, for that amazing talk. So we're going to go ahead and get started with the moderated session here. If the audience has any questions, if they could stand in line by Ryan, our coordinator, right there, and stand in line, and he'll pass on the mic in the queue so that you guys can ask the questions that you need to ask. We have a first question already. Okay.
I made you walk like 3 times yesterday already, so. First off, thank you for the fantastic talk. My question is, and I think Dr. Liu, you alluded to this, is that the patient plays a huge role in this as well, right? And a lot of why the costs are so high, and coming from somebody who do a lot of patient population analysis, we see, well, I see that the prevalence of some stuff, of some conditions in the US is just so much higher compared to Europe, etc., because the patients are so sick, right? And so I'm curious, how big of the chunk of the slice of the pie are related to addressing patient behavior before they reach the healthcare system? And is AI, and are you specifically looking at tools that can impact that portion of the patient journey?
Yeah, that's a great question. I mean, obviously not everything. I think healthcare is one aspect of this, and health is another aspect. And they're overlapping, but they're not the same. So there needs to be a larger societal shift around kind of the achievement of health. And that will have a lot of beneficial downstream impacts on the cost of healthcare delivery. But as I showed in the slide, there's, I think, a big role that health systems do need to play if they're organized around value, which is providing wellness and kind of the resources for patients to be engaged and the opportunities for them to really improve their health and prevent these downstream consequences. Some of that is things like screening rates, other things of that is education. We do have pilots in that. I myself am a user of a AI tool that we're going to be rolling out to 2,000 of our patients, where I lost like 25 pounds in 3 months by simply using this app and some wearables. So, I mean, I think it is important for a health system also to provide those as opportunities to bend this cost curve.
Hi, I have a question for Dr. Singh. So as I was watching, discussing about moving patients from Friday to Monday, the way I kind of saw that is like, what if my boss came to me and said, we're not really using computers too much over the weekend, so I have a great idea, you need to work over the weekend. We probably wouldn't take it very well. And you kind of mentioned it briefly with capacity, but capacity is, people not being able to see their kids, having to get childcare over the weekend, or have a constantly rotating schedule. And I guess where do these sort of the human factors of, caring about the healthcare workers and not just room usage and equipment usage, where does that come into play?
Yeah, it's a big part of it. I think the reason that we looked at Monday to Friday was especially because we assumed that, having surgeons come in on the weekend and having that be a regular thing, and not just surgeons, but all the staff, would just not be a tenable option to start with. So I think that, honestly, the clinician well-being, a lot of the clinical tools I didn't talk about are actually the ones that are really helping in that space. AI scribing technology with kind of the ability to do a lot of downstream tasks that you normally would have had to do manually, that's kind of initiated at the point of contact with the patient. AI that we use to draft replies back to patients that help clinicians get their replies out faster with less cognitive burden, where we've looked at what are the things that clinicians actually spend their time editing to try to fix those based on prompts. So I would say if you look at clinical AI today, I think when I said clinical AI, 5 years ago, you'd be thinking predictive AI, and you'd be thinking, oh, it's creating additional work through alert fatigue. Nowadays, when we think about clinical AI and generative AI in clinical care, almost invariably every solution is pitching a better clinical well-being as one of the things that they do. So I didn't talk about it here mainly because I think in the operations side, I'm looking at it from the patient perspective. If my patient has to get their surgery delayed 2 weeks because we don't have a bed to actually land them after they do their surgery, what does that mean for them? Obviously, you have to consider what does it mean for a system, and even just casually saying we can move 20% of our cases, people have clinic, people have lives, people have other commitments. So I think that you need that kind of thinking to be able to understand what's even possible. Because if someone came to me and said, oh, you could create 10 more beds, I could tell them, no, you could never create 10 more beds with that strategy. That wouldn't work. So that actually helps us make sure that the things that we're doing are backed by data, which right now I would say most health systems don't have the luxury to do that.
Hi, I actually have a question also about the kind of imbalance of admission and also operations happening in hospital. When I saw it, my first reaction is, oh, that's just doctors want to take weekends. And then I see the hospital registration also has that pattern. Then it hits me it's exactly like we have a work schedule, and patients and doctors have work schedule. We have weekends. And it's almost look to me like, okay, Friday is leading to weekend. Saturday, enjoy your life, and Sunday, oh, all of a sudden, okay, tomorrow I'm gonna work. So if I wanna be sick, I'm gonna be sick today, and so I do need to go to work on Mondays. I kind of feel like maybe another fix of this problem is outside healthcare, which is have a flexible work schedule for everybody, so you can decide when to go to the hospital or relax. So that's a comment, not a question. So I want to shift to another question, which goes to both of you, because a common theme of both your talk are talking about dealing with reports. Notes to reports, and to maybe extract information for further research or for further utilization. And it's all have a component that you should get as much original notes as possible, even combine them from different sources. And and then later on you talk about the cost. And I actually throughout this several sessions, during poster sessions, I met only one gentleman talking about, okay, there's a project using LLM, and this costs a lot of money in this. So I'm really wondering, when we were talking about the cost, there's money cost, there's the resource cost, the energy cost. I want to understand, for both your experience, what's in your cases, what's the real cost, adding together money-wise, resource-wise. I know, eventually if we save lives, it will worth it, but I do really want to hear more about, the real cost behind AI. What are they? Yeah.
I'll share a quick response to that, answer your comment, and then I'll turn it over to Vinny. So I think one of the reasons we are using LLMs outside of the EHR is we can choose which LLM to use. And I think that, training is expensive, inference is cheap. Training is very environmentally destructive. Inference, as there was a recent Anthropic paper that showed, is not nearly as destructive as when you compare the use of AI against a whole host of other things that we do, you can kind of actually map the resource use of AI in terms of its effect on environment and cost. So I'd point you to that Anthropic paper. But just to say that one of the reasons we chose the approach that we did was informed by the fact that inference is cheap. So it's really not expensive to build a 2-layer neural network as it would be to train a large language model from scratch. So for us, training a large language model from scratch was out of the question. And even for the other tasks, Llama 4 to me is a great example of a model that is very cheap per token and has a very long token window. And so it's not the best model for many things, but it's a model where it strikes a good balance when it comes to cost and just capability, because it saves you from having to do retrieval augmented generation for tasks where it's really an information extraction task. It's reasonably okay. The first comment you made, I'm actually going to flip it for you and actually give you a sense of what the reality is. If I told you there's 2 hospitals, one in which the doctors are available at 2 in the morning to do a CT scan at bedside in the ICU, which I've seen, for a patient who's about to go on ECMO, which is a extracorporeal, outside way of basically replacing their heart and lung function all at once. And there's another hospital that is closed on weekends, that basically nothing happens over the weekend. Which hospital do you think is busier? It's not the second one, it's actually the first one. So it's not actually that doctors don't want to work that leads to busyness, it's health systems that are the most well-equipped and highest resource that can actually save your life is where everyone wants to go. And I think the challenge is, how do you direct people away from those hospitals when they don't need those hospitals? And that's actually where a lot of the issues come from. Certainly well-being is important, but I think if we we improve the work hours at that busier hospital, things would only get dramatically worse, not better, from an operation standpoint.
Yeah, I think I'll just tie into that point. I think for most doctors, at least who are working in the hospital setting, are working on weekends already. So I don't think that's a new cadence for most. But I think there's a little bit of a moral injury when you can't do a surgery that you believe a patient needs in a timely fashion, right? And so there is a kind of a negotiation and a balance that could be achieved where, providers feel empowered to do the thing that they think is right, and patients are able to get it, and the system is load balanced appropriately. As to costs, I would say the approach of having many LLM options in the armamentarium is right, because I don't think we've seen those costs stabilize yet. We've seen them come down, but we don't know what the future is with increasing number of models, ones that are open weight, open source, and so I think being flexible and not adhering to this is the only model we will ever use is probably not a very sustainable path. But the cost of AI is very much in flux, and we've seen that very dynamically, probably even examples of that over this last week. And so I think, I think that's still yet to be seen, and how we think about contracts and negotiating costs. I would say that's very unsettled because of the pace at which innovation is occurring.
Hi, good morning. Thank you both for your presentations about kind of the implementation of AI and how we do this in a thoughtful manner throughout the system. My question goes back to the patient experience part of this. Kind of given the moment that we're in right now, where AI is becoming an increasing part of all of healthcare operations, how do you think about the ways in which we bring along those patients who don't trust these tools, or who are like all of our parents who barely understand their iPhones, let alone these AI tools that we're integrating in care, especially when it's not necessarily realistic for physicians to understand, the nitty-gritty of all of the tools that are being implemented, let alone, even just the AI basics?
I think there's a fallacy that older folks are not necessarily using AI. My mom was recently diagnosed with myasthenia gravis, and she keeps texting me from ChatGPT, like all the outputs and how she believes it. So, I mean, I think there's other factors besides age that are at play here. But I really truly believe with the pace of innovation that patients do need to be brought along. The tools should be dual purpose. They should be available to clinicians, and those outputs should be made available in a consumable way to patients as well. It's the only way that we're going to engender trust, and it's the only way, because generative AI does make errors, right? And if everybody understands we're working with this, this tool that is essentially trying to bring us insights, but there's cases where we need to correct it for sure. And I think the only way that's going to happen, not in an adversarial way, is for us to have patients engaged in that. And I think a lot of the mistrust of AI has to do with, sometimes it's placed in like cybersecurity, like is my data secure, or is it flowing to a company where they're going to be using it to profit off of it? And so allaying some of those fears or being very clear about those is one. And then I think second, there's the concern that it's disintermediating the interaction between a patient and a physician, let's say, that human touch. And I actually think no matter, I mean, the goal for I think most people in healthcare is that we actually strengthen that human bond, no matter how many layers of technology we put in between, but that we're actually bringing and making that interaction more meaningful. So, I mean, I think we're at a stage at which, you know, all of these tech leaders, and we're seeing it today, that the capabilities of these tools are outpacing, becoming on par or even outpacing what we can do as humans. It would be a disservice to ourselves and our patients not to take advantage of those, but do it in an aligned way.
Yeah, I think part of the trust issue stems from the fact that a lot of our AI to date has been clinician-facing, but for the patient. We're seeing more direct-to-patient AI, and so I think the people who really do want to use it will have the ability to use it, whereas when it's the clinician, the patient's not really often empowered to be in a decision to decide, or position to decide whether the clinician uses it or not. So I think the things that you can do is you can make sure there's disclosure when there's direct-to-patient, or where it's a patient communication, or there's documentation that a patient's going to read that the patient knows. Some patients won't like the disclosure. They say, I don't want to know if it's AI generated or not, or, you know, but I think that we view it as a kind of an important thing to do. There's a great editorial last week from Michelle Mello at Stanford that talks through, I think, some of the considerations around when to disclose and when maybe you shouldn't disclose, or when you don't need to disclose. And for us, the other thing is, in certain cases, consent. So there's still cases where things are new, where it makes sense to just consent someone, to let them know and give them the option to opt out, when it's really okay for them to opt out, which for more direct-to-patient stuff, it often is okay to let them opt out, in the same way that you can escalate a phone call to a human. And then we have our Chief Patient Experience Officer sitting on our Health AI Committee. So our AI governance includes direct input from the patient voice through our Chief Experience Officer.
Hello, good morning. Thank you both for the wonderful talks. My name is London Lowenstone. I'm currently a PhD student at the University of Minnesota, studying how AI systems react to populations that are non-standard or outliers. And there are kind of two ways that this often happens: is either people don't give responses, and so you don't have data to train on, or they give responses that are very different from all of the other groups that you've had responses from. And so I'm curious, I know you mentioned how once you know one healthcare system, you know one healthcare system, and also that equity is a very important part of healthcare. So how have you dealt with being able to provide equity for these populations or healthcare systems, however you collect data, for the groups that either don't have as much data to provide, and also provide different data than these other groups that you may be training your models on?
Before you answer that, I actually want to just jump in on that. You know how you just said one healthcare system, you only know one healthcare system? But even within the healthcare system, like each hospital is like very different. Like when you're a resident or fellow and you rotate through three different hospitals, like the local hospital, like the hospital where like transplants and ECMO happens, and then like the VA or something, very different patient populations. So excluding the VA for now, like between the community hospital and then like the more private hospital, you know, there's definitely differences. So how do you balance all that, and how do you know you're, you know, doing it right?
What I'll share is that, starting at a structural level, our chief equity officer sits on our AI committee. So that was a kind of a key commitment to make sure that the leads who are actually responsible for thinking about health system equity are actually there. So we don't think about AI equity, we think about equity for the system. And so I think that some of that follows from the way a model performs in a subgroup. Some of that follows from the way in which that model gets used to drive a decision and what resources we throw around it. And so I think that it's the answer is we look at it holistically. We are a lot less metrics driven than I think one might expect, mainly because the metrics often don't give you the answer you need in terms of what to do next. I mean, there's kind of those outlier cases, I would say, or cases like from Ziad Obermeyer where fixing the algorithm actually fixed the problem. But most of the time, it's some mix of the algorithm and what we do. And one of the things that generative AI has changed is that it used to be the case that everything was a predictive model trained at your system, which has existing inequity. Now it is LLMs trained across the entire internet, including Reddit and who knows what, that are guiding clinical care for our systems. So I think that it's just a whole different world we live in. And so we've tried to introduce mechanisms, even in our note casting approach, to try to handle and purposely withhold information from the models that we don't want them to consider as one way to try to make sure they give us consistent performance where it matters, where we think that it's going to weight something that it really shouldn't be weighting.
Yeah, I think that's right. I mean, this is a really important issue, but it's a vexing one because even if you metricize the measurement of variable performance by subgroup, there's always going to be a subjective decision in there about what the delta in performance, is that meaningful or not? But I would say this, I think you can take an unfair algorithm and deploy it in a fair way. That's my hypothesis. You can definitely take a fair algorithm and deploy it in an unfair way. So I think that overlap between what arises potentially from an algorithm and then how the system is designed around how that's used and ultimately measured, right? Because the proof will be in the pudding. If the gap between one group and the other diverges, doesn't close, or closes, I think that's going to be essential because we can't de-bias everything through math. It's just not possible. And then there's the human part about the choices made around that.
And just real quick, one actual example of that actually happening is at Case Metro Health. Yasir Tarabichian team had deployed a no-show model, a much maligned no-show model, and shown that deploying it in the right way actually improved no-show rates for minorities disproportionately better than it did for other folks. And so it almost directly addressed inequity if deployed in the right way. That's not always true, but that was an actual real-world case where I thought that was interesting to see.
Well, what do you mean by the right way? What sorts of things are you shifting?
So no-show model, what do you do with it? Do you double book patients? Or do you call people and offer rides to people who have a transportation problem because they're high risk not to show up? Yeah.
Wonderful. Thank you both for your responses.
Hi. I'm actually a postdoc at the VA, so kind of curious. I had two questions. One is around, so this is a lot about the technical and operations and sort of high level. I'm wondering, there wasn't a lot of talk in terms of advocacy and how AI can maybe drive that interface between at the higher government and systems level. Just areas to focus on in terms of that area of legal advocacy and such. So I'm sort of curious about your perspectives on that and where ML research can play a role. And also curious your perspectives in terms of more sustaining the AI system. As a researcher, fundamentally the things I research are impacted by what I've experienced in my life. And especially with AI, it can be the case that the people who come into this with that technology expertise or whatever can be from different populations. Do you see a role in terms of mentorship, some sort of programs for 10 years down the line, making sure that all of these different health inequities, that different people experience, those people have that AI expertise? Yeah.
I guess maybe I'll start with the second one, which is that in our experience about deploying use cases of AI, end users who know their domain super well are essential, right? Like even if it's like an ambient AI scribe, the ultimate kind of rubber meets the road of how it's used in an oncologist's office versus a psychiatrist versus an outpatient primary care doc are very, very different. And it might be the same underlying technology, but their experience of using it could be vastly different. And I use that as an example to say we need people in the AI development ecosystem at all levels from many, many different backgrounds. Because I think that they together represent many different perspectives, shared and lived experiences. And if we are to guide this and keep this technology aligned with our ultimate human values, then it needs to be representative of the diversity of those types of values. So that would be, I think that was the question you were asking. And you know, how do we do that and achieve that? I mean, that's a challenge, but I mean, I think with the pace of change, you know, again, AI is racing ahead. Yesterday we heard Dr. Mahmood say, you know, the pace of computation has exceeded our ability to benchmark. Like, we are in a difficult place because it's a rocket ship right now. And so how to make sure we have, you know, everybody on board is really, really going to be challenging over these next couple of years.
Yeah, I'll second that I think it is really important to, I think, mentor people, but that's why I said, you know, working with people who have lived experience in the system, whether it's as a patient, whether it's on the other side, they'll often understand issues really well in a way that other folks can't, or that you need a diversity of folks like that. Your first point was on advocacy, so I'll kind of just address that. I think not a week goes by these days that I don't email either our state government relations or federal government relations at the University of California, because there is so much policy change happening, which we need to weigh in on at the state and federal level. And so I would say any opportunity for public comment, we have put in public comments. We responded to the White House AI action plan public comment. We just responded to the one from NIH asking for, you know, ideas for their action plan. And we highlight some of the key priorities for us and say, like, as a system, we need to be able to study these things. And, you know, if the funding for like AHRQ goes away, where does that sit? How does that work happen? Can the NIH be a home for that kind of work? So I think it's important for us as a community, as a research community, as a health system community, to make sure that when those opportunities come up, that we speak up. And they're necessary but not sufficient, right? Like if those emails go to the dustbin or go to the garbage, like who knows whether those are even getting read, because nothing is happening in a really transparent way. So I think we've just been making sure that whether it's through private channels with congressmen, whether it's through public channels, through public comment, that we're engaging and helping people understand the realities of healthcare and that what it means to, you know, to see substantial federal cuts to research or substantial federal cuts to healthcare in terms of our ability to innovate in that space.
One last question.
Thank you so much. My name is Jorge Rios. I am a postdoctoral research fellow at Mayo. And my question is like, I think healthcare is impacted by many social and cultural phenomena constantly, right? So I was wondering what measures you take to keep updated your models, your systems, and what are the biggest challenges that you have encountered towards that problem, and also what are your recommendations or tricks to handle that? Thank you so much.
I'll share one thought on that, which is actually in one of our public comments. So the public comment, one of the points that we made is that right now, because of Office of Civil Rights and other laws, you cannot use machine translation anywhere where accuracy is essential. And what that effectively means is that if a patient doesn't speak English and sends you a secure chat message that's asynchronous, that if they send that to you in English, you can easily respond. If they send you in another language other than English, most systems are not equipped to handle that. So some systems have the ability to route that to a translator internally. Many systems, probably most, don't. And so what patients do is they actually run Google Translate on their side, convert it to English, send you the message. This is my hypothesis. I don't have proof for this, but I'm almost certain this is what happens. You respond to them in English because they wrote to you in English, and then they translate it back to whatever language they do. So I think that this is a one space where AI actually has a lot of capability for short, accurate messages when, like defining what does it mean that accuracy is essential. The current status quo sucks. So I think that we can probably deliver more culturally relevant care if we relax some of the restrictions which were put in place for very good reasons to allow us to do more kind of culturally sensitive, which often translates to language first kind of things where we don't have the workforce. It doesn't exist for us to do individualized translation for every communication. I wish it existed, but I don't think it does.
Yeah, that's the same thing. Good example. That's a reverse discrimination. Like, it was intended to reduce the discrimination in the health system being having ineffective communication, but by limiting the opportunity to use these tools, which are not perfect but quite good, to be able to communicate effectively, we're actually giving a lower level of care, unfortunately, to these patients because most health systems are simply unequipped to do that. So, I mean, I think those are, I mean, we have to, again, be really thoughtful about how we're deploying AI. Governance is really important, including different stakeholders who are looking at this issue from different angles to try to deploy it in the safest way and then to monitor those outcomes.
All right, well, thank you, Dr. Singh, Dr. Lou.
Thank you.
Coffee break time.
That was fun.
Good morning, everyone. We are going to get our roundtables started. These will go until 11:30. There are three topics to discuss. The first, accelerating generative AI from concept to care, foundation models in healthcare, and causality. So we have three tables set up. Let's see, this one here reads causality. That one reads, I don't know. Okay, causality, foundation models in healthcare, and accelerating Gen AI to practice is there in Jihan with the red. Thank you. These are optional discussions. You're welcome to join. Unstructured, going till 11:30.
Hello, everyone. Just to let you know, we do have lunch served in the back. Feel free to continue your conversations, but just so you know, lunch is available, and then we'll do the poster sessions afterwards. Thanks.
So as people are coming in, we have one announcement and actually a more important thank you.
All right, yeah. Jim and I are both on the board for MLHC, and we wanted to thank the program chairs this year for helping us put on something that was fantastic. Specifically, we had all different parts of this meeting, who were Shamali Joshi, who is right there, Kai, and then Inigo Ortega, who is right there. If we could give them all a round of applause, that'd be great. In addition, the conference doesn't really go without sort of like making hard decisions on like papers and clinical abstracts, and our who are Matthew Engelhardt, who's I'm looking for somewhere here, and Shenpu Tang, who's back there in the back. And then finally, it's been a fantastic play for our local organizers, who are David Vidal and Shauna. And then Jim has one announcement left.
So next year, the 2 to 10, and we will have a feedback session at the end, so you can push back on this. But we were thinking of doing this on a Wednesday, with the workshops on a Wednesday, and then the meeting on a Thursday and Friday, rather than having it drag into the weekend. I don't need a show of hands, but if you've got feedback on that, shoot me a note. And then the other one is, we're going to move from the Midwest to the East Coast, and next year's meeting will be at Hopkins in Baltimore, which is my hometown. A long story. But so I will be one of the local hosts. And again, look forward to the enormous help from the program chairs, the workflow chairs, and the communication folks, and the finance folks. It's really an enormous amount of work to bring this all together. And again, just want to say thanks to all the folks who made this happen. And look forward to seeing you all in Baltimore a year from now.
So thanks to the board also for giving us guidance on the organization. And with this, we're going to start the final session of MLHC 2025. And it's a pleasure to have 2 speakers today that are coming all the way from Europe, so also appreciate the effort of joining us. The first speaker is Dr. Julia Bod. She's an assistant professor in computer science at ETH Zurich, where she leads the medical data science group since 2019. In 2022, she was awarded an European Research Council starting grant, which is one of the most competitive grants to fund high-quality research in Europe. So Dr. Bod, she's a great advocate of interdisciplinary collaborations, as you'll see in her talk. She takes research all the way from computer science, basic research, to in the implementation side of things. We feel that she fits MLHC very well, so please welcome me on introducing Julia and letting her present her latest research.
Thank you very much. So thank you very much for the introduction, and also I would like to thank the organizers for inviting me here. So it has really been a pleasure being here. I really like this meeting. It's exactly the right size. You meet people again and again, and you have great conversations. So it's really been great. So thank you very much. And now I will talk a little bit about what we do at ETH Zurich, especially in my group, in my research group. And as was announced, I'll try to bring the models we develop into clinical practice. We are not quite there yet, but I will tell you what we do and where we are and what the challenges are. So the overall aim of my research group is to improve patient care with machine learning. This is what we aim for. And we are a computer science lab. So we are in this corner here. So we are the machine learning researchers. We have a background in computer science and mathematics, maybe in physics. We do not work with patients. We are not generating data. And this means if we develop models by ourselves,
it might be likely, so we will develop great models, of course, that are efficient, that do great stuff, but it might be that we develop models that are actually not usable in practice. And to achieve our aim of developing models that actually help patients, we need our clinical collaborators that are on this other side of the island here. And they have the data, they develop, they work with the patients, they know exactly what their clinical needs are. And I work at this intersection, so it's important to me to bridge this gap and to find projects that have a clinical impact and also a methodological contribution. So we develop machine learning models mainly in the areas of multimodal learning, unsupervised learning, generative models, also interpretable explainable AI that have a methods contribution, and this is what we publish in the machine learning venues, and then we implement this for the clinical like use case and publish this in the biomedical domain. So we walk this often narrow path of what is methodologically interesting and also has a clinical impact. And for this, the clinical collaborators are very important. And as I said, I try to find projects that are interesting to us from a methods point of view. So the application area differs a lot. So I try to find projects where the data is interesting, the problem is interesting, but we do not have like one specific type of application. The application varies, and here you see a few examples of projects we are working on. One is, for example, in rehabilitation. Here we help detecting gait patterns in patients suffering from stroke. So we have these sensors that are all over the patient, and we monitor how the gait pattern changes given some incentives, and this is what we do in this project. We have a project on sepsis in neonatals. We have a project in appendicitis, in detecting heart defects, on phenotype extraction, on neurological disorders like general movement assessment in newborns, also on rare diseases and on type 1 diabetes. So these two projects actually have been presented here. So they were in the last few poster sessions presented by my students. And I will focus on these two projects in this talk. So to give you two specific examples, what we did in these cases and where we stand. So I will start with a project on detecting heart defects in newborns. So the idea here is to detect congenital heart defects. So congenital heart defects are heart defects that are present at birth, and they affect the structure of a baby's heart and the way it works. So they can be structural or functional. Structural meaning there might be some holes in the heart, or functional, it might affect the structure of how the heart pumps the blood. And those are usually diagnosed with echocardiography, so with ultrasound. And early screening here is really crucial to ensure long-term health of these babies. So if these heart defects are missed and only found out later, the baby or the child might already suffer from consequences. So the earlier detected, the earlier it can be treated, and this is what we aim for here. And here you see 3 examples of these congenital heart defects. So this is how a normal heart looks like, and this is this defect called CAVC, where these heart walls are all not connected. Then another congenital heart defect is this VSD, where there's a small hole in this lower heart wall here, or the Epstein anomaly, where this heart wall here is not closed. So these are a few examples. There are more. And we work on this on ultrasound data. So what we get is we get these ultrasound videos from newborn babies. And these ultrasound videos are quite cheap to acquire, but they're very noisy to interpret. And this is already the case for adults, and it's even more challenging for newborn babies. So here's a photo of our collaborator in the University Hospital in Regensburg, where he performs such an ultrasound on a newborn baby. It's a preterm baby, so you see they're really tiny, and also the hearts are tiny. And in addition that it's really challenging to see these heart defects quickly, even if parents are around, they might ask questions, they might be nervous. So it's really a stressful procedure, and it can take quite some long time, but you don't want to stress the baby too long, so it should be fast. And in addition to this, it's also that the heart of the baby changes a lot in the first weeks and months. So what is normal directly after birth might already be abnormal a few weeks later, so also you need to take this into account. And this is where the project started. So they contacted us, they said we have these heart ultrasound videos in different angles. We get them in 5 different angles. So depending on where you place the ultrasound head, you get a different angle of the heart, and depending on the angle, you might see the anomaly. So this defect, you might not necessarily see these holes in the wall in every of these views, but in some of these views. And this is why we want to have all these views and take all this information into account, because in some of these views, actually this defect might not be visible, but in another, it might be visible. And this is what our starting point was, to start with these ultrasound videos. So now these congenital heart defects occur quite rarely, so they're not too frequent. But what is done frequently is these echoes of the newborn hearts, and this is during standard screening directly after birth. So we have many of these videos actually from healthy babies, but not too many from babies having this heart defect. And this is why we approached this using an anomaly detection approach, where we developed a model that builds a model given this healthy hearts, these healthy videos we have. So we build a normative prior of the healthy heart, and then at test time we can see if the heart we look at is actually healthy or diseased. So this was the idea behind it. And an observation we have is that the heart beats periodically. So we have this periodic heartbeat. The videos are approximately periodic, and this is what we would like to use. This is what we like to leverage. So the idea was that we use here a variational autoencoder that mimics this periodicity, and we model prior and posterior as distributions over these periodic functions. So this is the idea. We have we reconstruct how a healthy heart would look like. Then we subtract this reconstruction from the video we look at, and then we finally get a visualization of differences of the heart we look at, how it differs from a healthy heart. And then we also can pin down where actually the differences are. So we see here in this image where the model thinks the heart differs from a healthy heart. And this is something that is useful for the clinicians, that they can actually like zoom into these regions where the model thinks that these hearts deviate. And this is the structure of the model. So it's a VAE-based approach. So we have an encoder-decoder model. We have here some prototypical function. We also learn the heartbeat, and we get some parameters that describe some specific features of the heart. And for this function, we have three different versions. One circular version that takes the periodicity into account, and then a rotated version that also distributes the time component over all dimensions, and also the spiral version where we also take care for spatial dependencies and spatial shifts, which is especially important because we might have zooms in and zooms out in these videos, and this is what this spiral model then can capture. And this is how an example of videos, how the final model looks like. So on top here you see the original input videos in different views, and here you see the three different versions of our model. And here are healthy hearts, so these are examples of healthy hearts. And then you see that this is all these shades of blue. And for anomalous hearts, you see that here it detects these anomalies, and it shows us where these anomalies are. And this is what we call it has an explainable component, because we not only tell our collaborators this heart is probably healthy with a specific maybe variance, but it also, we can show them where our model thinks the heart deviates, and so they can look actually at the specific region and see if they find something there or not. And this was work done by these students. We have been working on this over multiple years, so it started. Actually, the first paper was actually published at this conference in 2002, and then we had some different types of work looking into specific congenital heart defects, and also ejection fraction and Epstein anomaly and these types of things where we had some follow-up work on this. And now I was talking about this explainability component. So I have learned, or I've realized in my last years working with clinical partners, that for some of them it is actually helpful if we can explain what is happening and that it's not a complete black box. And also my experience was in my very first years as an assistant professor, we had a predictive model. It worked very well. It was a black box. And we wanted to actually build a company out of this and build a startup and bring this into the market. And in the very early steps, we realized that as this is a black box, this European German General Data Protection Regulation has a right for explanation, which was not fulfilled. So they decided very quickly that the machine learning part is out. And I found this quite sad. So then I thought, okay, we probably, at least sometimes, need some models that are explainable or interpretable. Sometimes because it helps gaining trust in clinical collaborators or helping us to convince the founders that is actually all these checkboxes that are needed to go through a certification process are checked. And this is why I also started to look into this more closely, and this is just a terminology. So I differentiate between interpretable and explainable models, and this is not a definition that I made, it's just a convention, so there is no clear definition what these terms mean, but this is what I mean when I talk about it. So with interpretable, I mean white box models, where we understand how a model works, and here are some examples of what is usually considered to be interpretable models. And for explainable models, I mean more black box models, where we explain post-hoc what is happening, and this is what the example you just saw, where we have some visualization, and we see what is, so the model itself might be a black box, but we explain later on what is happening. And in the next few minutes, I will focus on this interpretable high-level concepts, where we use human understandable features, human understandable concepts to insert some interpretability layer into the model, and also a layer that makes it feasible for a user to interact with the model. And this we built in the context of pediatric appendicitis. So this is a project where we were approached because it still seems to be difficult to correctly diagnose appendicitis, and also the management and its severity. And when I was approached with this, I was surprised, because I thought appendicitis is so common. But obviously it's still very difficult to actually diagnose correctly. And at least in Europe or in Germany, it is the case, if it's diagnosed, if you're in appendicitis, you can decide if you treat it surgically, so if you remove the appendix, or if you treat it conservatively, give some medication. And our collaborator said that the surgery is performed far too often. So in this project, they want us not only to correctly predict the diagnosis, but also to tell them, is the surgery actually necessary or not? And how likely is it that there will be complications? And if it's the probability for complications are high, then it's more, we should take this operation. So the aim is here to reduce unnecessary surgeries. This was one of the aims in this project. And we started first with tabular data. So the data here is collected if a child, so this is an adolescent, like very early child to 18 years, and if they come to hospital, data is collected, like there is usually an ultrasound examination done, where one has some ultrasound findings, some physical exams if the patient has a fever, and some lab tests are done. And we first started with this tabular data, where we used tabular data and some classical machine learning models to diagnose this, and this worked very well, so everyone was very happy. But we thought, okay, this is only actually on the tabular data, and we did not make use of the raw ultrasound images. But it would actually be quite nice if we can just take the ultrasound images and, based on these images, predict our outcome. And this is what we did in the next step. We tried to make use of these ultrasound images directly. And for this, we proposed a model. This is based on concept bottleneck models. And the concept bottleneck model works in a way that first human understandable concepts are predicted, and then the target variable. So this means here we have an image as an input, and then instead of going the prediction directly from the image to the target, which in this case would be the diagnosis of appendicitis, we first predict human understandable concepts, and then we go from the concepts to the target. So this is the workflow in a concept bottleneck model. And then one can intervene on these concepts, and this is what makes this very nice, because it adds a layer where one actually can interact with the model and see how the outcome of the model changes if I change these layers inside here. So the limitations of the vanilla version of these concept bottleneck models was that they can only deal with single inputs. So as a first step, we extended this model to be able to deal with multiple inputs, because we have multiple ultrasound images. So this was the very first extension, to be able to deal with multiple inputs. And then for this, we need concepts, right? So it's a concept bottleneck model. We need to predefine concepts. And these are 9 concepts that were defined together with our clinical collaborators in this project. And these are, for example, if the appendix is visible, if there is fluid, how the appendix layer structure looks like, if there's a surrounding tissue reaction, and so on. So we defined 9 of these concepts, and this is what we used. So this means if we have this ultrasound image, we first predict these 9 concepts that are predefined, and then given these concepts, we finally predict our diagnosis. So this is what happens here. And this is why it's called a bottleneck, because it's really the final prediction is only based on these concepts. And then we can also intervene on these concepts and change these values. And what I mean by intervention, so it's not an intervention in a causal sense, it's really just changing these features. And this is a made-up example. If we have this ultrasound image, and then we have our predicted concepts, so here it might be that the appendix visible is a very low probability, free fluid as well, and then the prediction algorithm says no appendicitis. But if our collaborator looks at this and says, actually, I see very clearly that here there is some free fluid and also the appendix actually is clearly visible, one can manually adjust these concepts, change the value, and then by changing the value, we get a different prediction. And this is what intervention means. So there's no causality involved, it's really just changing values, and with changing these values, we get a different prediction in the end. And now I showed you this concept set we have. So we have these 9 concepts, and this concept set is actually often incomplete. So this is a very small concept set, right? If you look at the whole image, you make a prediction, and then you go from this whole image to this very small set, it might actually see that there is, what happens is a so-called performance interpretability trade-off. So you add this interpretable layer, you have these concepts that a user knows what it means. However, the performance might drop because you restrict yourself to a very small set. And this is not what we want. So our question was, can we actually resolve this trade-off? Can we have an interpretable model? Can we have these human understandable concepts, but not suffer from this performance drop? And for this, we developed a new model, which we call semi-supervised multi-view concept bottleneck model, where in addition to this concept bottleneck arm, we add an unsupervised encoder, where we learn features in an unsupervised way, and we add regularization step, where we make sure that these predicted concepts and the learned representations are independent conditioned on the label, because we do not want to learn some redundant concepts. We do not want to learn something similar again. We want to learn something in addition. And then finally, given these concepts and the learned representations, we predict our target. So this is then our final model. And as a reminder, we need these 3 tuples. So we need the input data X, we need the labeled concept C, and we need our target Y. So this is the input we need. And then what happens first is, we extract view-specific features from every view. Then we fuse these features across the views, and then we do some concept representation prediction. So the concepts are predicted and the features are learned. And finally, these are concatenated. And with this final concatenation, we then learn our target value, in this case, diagnosing appendicitis. And then we can, at test time, still intervene on these concepts. So this we did not lose. And with this, we can handle multiple and varying number images per subject. So we can handle these multiple ultrasound images we have. And we can also handle incomplete observed concept sets, because these concepts might be too small. It might be because it's costly to annotate them. It might be that there's just no knowledge that there is something important. And with this semi-supervised arm, we avoid this. And here you see some results. So this is how a random model would perform. Radiomics plus RF means we extract features from the imaging and just train a random forest, where performance is not so good. But then here you see the single view black box model and the single view concept-based model. And here this performance interpretability drop happens. You see that the black box on just one image performs better than the black box if we restrict it to this concept set. And the same for the multi-view model. So the multi-view black box performs better than the multi-view concept-based. And we do not see this drop with our semi-supervised model. And here as a reminder, so our aim is not to beat state-of-the-art models. Our aim is to be on par, but having this interpretability component. And this is why we were quite happy here that we achieved this. So we have now our interpretable concept sets, and we are not worse in performance than the black box models. And now the question is, so what happens now? So do we stop here? So we now have our model, we have our research paper, and if we stop here, what happens? So ideally, I would like that this is implemented and helps actually in the clinic. And here I would like to cite Duncan Watts, who put in words what I was thinking. And he said, for 20 years, I thought my job was, as a basic scientist, to publish papers and then to throw them over the wall for someone else to apply, right? This is what we often do. So we write a paper, we think this is great, and now someone, please apply it to your domain. But especially if you're working in these interdisciplinary fields, it's quite unlikely, or at least in many hospitals, it's unlikely that the clinicians will go to our GitHub, download the code, and use it for the data. So this is why he also realized that there is actually no one on the other side of the wall, just a huge pile of papers that we've all thrown over. So this is not what we want. We want that this is actually used and helpful. And the first step that I think might be important is this transparency step, and this is what we have. But what we still need is we need some tool. We need something that is actually usable in daily clinical life. And this is what we did as the next step. So we developed this pediatric appendicitis prediction tool. This is freely available. And this is the screenshot of the landing page. And this is what all these red banners I had to add for ETH. Because ETH Zurich has no liability, it's a prototype, so I had to really make sure no one can sue us, and it's like not be used for medical purposes, it's for research purposes only, and so on. So it took us some time until we were there that they were happy with us putting this online. And this is where we are now. So we have two versions of this tool, one for the tabular data and one for the imaging data. And here you see the tool for the tabular data, so this means really the clinician types in these values, and this is a real case. This was a 3-year-old child that came to the hospital, and then the height was noted down, how heavy the child was, the body temperature. And what one needs to know is for children in this age, at least this is what I was told, is that appendicitis is not so common. Intestinal infections are a lot more common. And children in this age are often unable to really communicate that the pain is different than what they usually have if the stomach hurts and so on. So just given, so the clinician looking at the child decided not to perform surgery. But then they put these numbers into the tool, and actually the probability that the patient has appendicitis was quite high, and also the probability that the kid needs surgery was quite high. And in the end, the clinician decided to perform surgery on this kid, and it turned out that this was really necessary because there was already some surrounding abscess beginning, which can lead to complications. And so this is just one example, right? It's one anecdote, but I know this anecdote because the clinician sent it to me and said he was very happy, and it changed the surgeon's mind, what is apparently not that common. And now we try to monitor this more systematically to see actually what does our tool predict, how do people use it. But so far it's really just out there and it's not monitored in any way, and now we want to change this and see what are the cases where it helps in what way. And then this is the tool for imaging data, because I thought you really need to type in many values, right? And this is kind of annoying. So what if we can just upload the images? And this is what the idea of this imaging tool was, that we can just upload these images, and here you see how it works. So the clinician uploads the images, then these images are pre-processed, and then as a first step, the 9 concepts are predicted. And here you see these concept predictions with the histogram of the prediction of the training data in red for appendicitis and in blue for not having appendicitis. And as a second step, then the target variable is predicted. So here the risk for having an appendicitis. And as the last step, one can intervene on these concepts. So here you see these yellow boxes is where an intervention happened. So the red arrow is the value before the intervention and the black after the intervention. So we change these values, and by changing these values, you also change the probability for the outcome. And So the manuscript, the dataset, and the tool are publicly available. And I would like to emphasize that I'm especially happy that we could publish the dataset. This is actually nothing we can usually do. So here we were very happy that our collaborators agreed, and also ETH agreed. This was also a long process, but here we can really publish all of it. And yeah, these are my students who worked on this. It's also like, has been a long process. And it's now in the process that we finished this on one hospital, and now we are in the process of collecting data from different hospitals to see how does our model actually translate to other hospitals, to other settings, to other ultrasound machines, and so on. And yes, so these are about 2 projects I wanted to present to you today, where we developed the models and we tried to bring it into clinical practice, and it's at least something that's out there. It's not, not certified. Not a real medical device, but at least it's something we can give our collaborators at hand, and they can use it whenever they want. So, and this is only possible with my national and international collaborators. As I said, ETH, we do not have a hospital, so I really rely on one-on-one collaborations. And these are my collaborators I work with, and I would especially thank my research group that works with me on all these projects. And now thank you for your attention. Thank you very much.
Thank you, Julia, for such an inspiring talk. I guess we'll leave the questions for later. And let me now introduce our next speaker, Dr. Chris Holmes. He's a professor of biostatistics at the Department of Clinical Medicine and the Department of Statistics at the University of Oxford, and also the director of AI at the Ellison Institute of Technology. He has a background and expertise. I recommend his books. He's been recognized by many awards, and particularly by a couple of the Royal Statistical Society. Recently, he has been focusing on applications and statistical methods for the development in the genomic sciences and genetic epidemiology. He's currently a program leader grant. He holds a program leader grant in statistical genomics from the UK Research and Innovation Medical Research Council. And I think today he's gonna talk us about a particular use case in which he used all these statistical machine learning approaches to solve healthcare applications. So welcome, Chris Holmes.
Thank you. Great, thank you so much. And thanks to the organizers for inviting me to this wonderful conference. I've really enjoyed it, and I've enjoyed the discussions and the format. I think it's a really nice pace to the conference. So yeah, I have 2 affiliations just to flag. I'm Director of AI at the Ellison Institute of Technology, which is in Oxford, but it's not part of the university. It's a separate institute funded by Larry Ellison. And secondly, I'm a Professor of Biostatistics at the University of Oxford. I'm going to talk to you today about a piece of applied research that we did that is, I was hoping it was going to come out by the time, but it hasn't quite. So it's coming out, I think, on Thursday in Nature Medicine. And you'll see this rather odd kind of title, the kind of that I've put up here, is that this is the title that we submitted to Nature Medicine. Reclassification of MS using probabilistic machine learning. And then we got a note from the editors saying they really wanted AI in the title. And I was thinking, well, you know, it really is just probabilistic machine learning. It's not really AI. But I'm not going to retract the paper once it's kind of accepted or close to being accepted. So this is the title, an AI-driven reclassification of MS progression. But realistically, or really, it's just a very careful application of probabilistic machine learning. Hopefully, you'll think it's careful by the end of the talk. So the focus of the study is on MS. which affects around just under 3 million people, at an estimate, worldwide. So 1 in about 3,000. And its characterization is by physical disability and relapse. And when we came into this, well, currently, when we came into this analysis, the standard clinical classification is around 3 states. Relapsing, remitting MS, where you have these bursts of deterioration, but you recover from them. Then you have a burst of deterioration, but you'll recover. But slowly these recovery times reduce over time, and then it's just gradual progression. But these characterizations, these 3 kind of states, are seen as distinct. And secondly, we're based purely on physical kind of disability. And what we sought to do was to say, well, what's the kind of evidence, what's the data-driven evidence for there being 3 states? Maybe there's more states, maybe there's less. Yeah, so rather than doing a qualitative characterization of the states, is there a quantitative data-driven approach? And in particular, can we use medical imaging, brain imaging, to be able to characterize the intrinsic dimensionality underlying the disease progression? The other thing to note is MS is very heterogeneous. So whilst there are kind of 3 states, some people unfortunately move very rapidly through those, others more slowly. So the current state of the characterization or classification of MS, as I said, are into these 3 states. We've got the relapsing remitting, which is at the beginning, where you have these, as I said, these short bursts, but you recover, and the recovery kind of slowly deteriorates over time, these episodes. The limitations are that they don't take into account any quantitative brain imaging analysis. They're not very predictive of how you will respond to treatment. So being put into one of these 3 stages is not predictive of how you will respond to treatment. The prognostication is coarse, as in it's not a high-resolution prognostication. And I think this people have said has kind of hampered the development of treatment, because do you develop treatments for each one of these 3 classes, or should you put people together? So the goal is to do data-driven reclassification using both clinical information and MRI brain imaging, and to ask questions, how many kind of latent states are there? Can we identify those? I should say this is a collaboration with Novartis and the University of Oxford. And it's been noted, this is a Nature Reviews from 2018, that there was really kind of a demand for more quantitative approaches. The traditional kind of course descriptions are based on clinical presentations rather than perhaps the kind of underlying disease biology. So through discussions with Novartis, we decided to set up a big study to try and explore this and say, what is the evidence behind those 3 states? If we go purely data-driven, do we recover those states? Are there other states that we would do? So we put together the largest and most comprehensive clinical trial data set in MS. This involves extracting 34 clinical trials over 20 years. There are around 35,000 patients with around 200,000 brain images, MRI scans for those patients, with about 15 years of follow-up. So we've got about just under 90,000 patient years in this in this data set. It's a really major task to harmonize this data. It took us 3 years of a data wrangling team to put that data set together. Moreover, so we had to set up a secure research environment with the correct levels of information governance within the University of Oxford. So this is a firewalled research environment where we could put the data in. We had to anonymize the data, so remove patient identification. There's actually in the brain imaging, certain brain images have patient identifiable features. So you apparently get the front of the brain, so the nose and the forehead. So for one of our data wranglers, bless him, spent 3 months going through all of these brain images, identifying if there was identifiable features, and then removing them. At the end of the 3 months, they had to leave the project because they'd had the identifiable. So big thank you to that data wrangler. So we have this very, very large, comprehensive data set. What we wanted to do is to use then, rather than think about these discrete subtypes, can we build a probabilistic model that looked at a continuum, a trajectory of disease progression, rather than 3 states where you're in state 1, and then there's a jump to 2 and 3. And to do that in a kind of a data-driven way and identify, if we have patients that are on a degeneration trajectory, how many kind of states can we do? Can we identify or clearly identify? And how do patients move through those? So to do this, we used a particular approach in kind of statistical machine learning or computational statistics called probabilistic factor analysis. So we've got a number of measurements on each patient. Actually, we've got a number of summary kind of measurements, around 8 on the patients. So we've got a number that are derived from summary statistics from the brain imaging, like lesion volumes. We've got others about physical tests that the patients have to do. We wanted a generative model for the patient measurements such that we get a likelihood function from the generative model. And also, a lot of these measurements are highly correlated. So there's a lot of the kind of the physical measurements that patients do, there's really strong correlation. So you want to take that into account in terms of identifying the kind of driving factors. If you're going to go in and identify subtypes, it's really important that you take into account the kind of covariance and dependent structures between the measurements. So what a probabilistic factor analysis model looks like is to say that the observed multivariate, multiple modalities that you measure on a patient are kind of driven by some lower dimensional kind of latent structure. So rather than kind of 8 measurements, maybe there are 5 intrinsic dimensionalities to those 8 different measurements. For those of you that work in probabilistic models will know one of the features of a factor analysis model is that it's rotationally invariant. Which means that you want to code it in a way that identifies certain features. And one interesting thing is this feature called sparsity, which says if we induce sparsity into the model, then we're more likely to pull out kind of more identifiable features. So we used something called a spike and slab prior in Bayesian analysis to try and favor sparse representations in this factor analysis. And we also treat the number of latent variables as unknown. So can we use the data to actually dictate or suggest how many latent dimensions are in the process, rather than us putting down and saying, oh, there's 2 or there's 5. And to do that, we used a Bayesian, something called a Bayesian non-parametric prior in here. The other aspect that we face is the non-uniform sampling times of patients. So here's the kind of structure that we're looking at. And we use something called a hidden Markov model to do this. So we've got a patient enrolls on the trial. We have a lot of measurements at time 1. But then there might be a big gap until they come in again. Then we'll get some other measurements, and we'll get some other measurements, and so. So this is a non-uniform. We've got a non-uniform visit times between the visits. Now, originally, we thought about using what's called a continuous time Markov model. So we said, oh, that's OK. It doesn't matter. Like when they come in, we can just model that as a continuous time. Then we get an observation. Then there's some arbitrary time interval. But when you do that on the dimensionality of the data we've got, the size of the data set, it took about 12 hours to do one run of the model. And that's fine if you've built the model, but it's not fine if you're building the model, because you want to touch the data lots of times, because there's lots of kind of tweaks to the models, or lots of the kind of things that you want to do in the model building. So in order to do that, we discretized the data. So go from a continuous time to a series of discrete intervals, monthly intervals. And when you do that, of course, you introduce a whole load of missingness. So we've got this idea of we've got some unknown latent dimensionality. So that was like unknown number of states. That's the thing we're trying to infer. We've got some things that we've seen, the observations. And then we're treating like if the first patient came in, well, they come in initially, and then the next time they were seen was in month 4, then we've got like 2 missing months. But one of the nice things about the hidden Markov model and these kind of probabilistic factor analysis is that you can, what we call, integrate out the uncertainty in these states. So you can treat that as just missing data and still get the models to run efficiently. So the way that we model the outcomes, we've got 8 measurements per patient, some which are physical, some which are derived out of brain imaging, like the T2 lesion. We've got various amounts of missingness in these different in the different measurements. So like one of the physical measurement is a timed 25 feet walk. That's typically has about 1/3 of the data is missing on that. But because we've got a generative model, this probabilistic factor analysis model, that's fine. We can kind of almost impute that through. Once we do this and run this on that large data set, what we get is the following. Is that the model identifies 4 factors that seem to describe the observables, the clinical and the brain imaging derived measurements. And with experts, these are our labels. So these are subjective labels that we've called them. Here you're going to see the sparsity. I remember I mentioned this about this using a sparse factor analysis model. So this means in the so-called loading matrix, we get zeros, which is really nice for the interpretation. So we see the first factor seems to capture physical disability. And you can see why this is based on the kind of measurements or physical measurements that are taken on the patients. The second factor we call diffuse brain damage, because it's picking up a lot in terms of lesion volumes and brain volume for the patients derived from the brain imaging, as well as a cognition score. there is a relapse, which is just a qualitative yes/no on whether the patient has presented with a relapse. And we can see that that's accounted for by a single factor. This is quite nice because it says, well, this is a variable which is pretty much independent of the other variables and is really informative for prediction. And then finally we got something which we call asymptomatic, which is based on the MRI scan. This is an interesting factor because you would miss this factor if you didn't have the brain imaging. So that drives the factors in the two observables. And then the next question is, if we have this as a hidden Markov model, what is the intrinsic number of states that we see within disease progression? And we use something called a BIC, which is a Bayesian information criteria. It's a way of kind of scoring models, particularly useful in nested models where you're kind of increasing the dimensionality. And what we found is that the data suggests that there are kind of 8 underlying states of MS. We're going to cluster them down to kind of 4, essentially. But they're nested, so we've got 8 intrinsic states of MS, which is given by data-driven analysis. These kind of cluster together, so states 1 to 3, if we look at, sorry, I should have said these figures here are the average measurements, the expected measurements of patients that are sitting in those states. So what we can see is in states 1, 2, 3, we have low measurements. Sorry, the bottom one is the kind of lesion and relapse. So we're seeing in states 1 and 2, we're seeing low levels of physical and cognitive impairment. At the other end of the side, in states 6 to 8, we're getting high levels of impairment and high levels of central nervous system damage. And in the middle, we have these kind of transitory states between the turn of two, between those two extremes. This is what the hidden Markov model looks like. And this is this kind of diagram where the arrows are the transition probabilities that were derived from the data. Gives you a course for the trajectory of patients. So suppose you're starting in state 1. This says with certain probability you will move to state 2. And then if you're in state 2, there's a high probability of going back to 1. There's a small probability of going into 5 from 1. So by modeling these transitions, we get to see how patients on a patient trajectory will move between these states. What's really interesting from this state transition diagram is that you only can move, it only appears that you transition to the high level of impairment through these transitory states. There's no arrow that takes you from 1 into 6 or 7 or 8. So this model models the kind of dynamics of patients. It also suggests that we can cluster them into the kind of 4 clinical states. When we looked at the original classifications that came about that people have traditionally used, these 3 classifications, they're not that well distributed across the states that we see. And what that means is that there's little overlap between the traditional classification of MS and the data-driven classification of MS, which suggests that perhaps there's a misalignment between the original classifications and what's actually happening in the underlying disease biology. So we can label these things as early MS, which is the blue states. We've got this transient which includes an asymptomatic state, which you only get to see if you've measured statistics from the MRI brain imaging, and then the evolved MS states. We can look at the transitions from the early states through to the evolved states, and we can look at what happens under treatment. So under disease-modifying therapy, when we overlay those patients with the particular, because it was a randomized control trials, this is all derived from randomized control trials, what we can see is that the effect of treatment is to reduce the transition from the early MS states into the transient states. But seems to have little impact in the evolved states. It also, because we have a probabilistic model, we can characterize the evolution and the trajectory of patients through this. So we were really pleased on this, yeah? Well, I mean, it was exciting. We'd got this, we'd spent ages, 3 years putting the data together. We found this, what we thought was really interesting. We submitted it to Nature Medicine, and the reviews came back and they said, we really like it. We'd done cross-validation, we'd done held-out data, yeah, that we'd never used, and then we put it through the model, and they said, we'd really like some external validation. So, oh, it's like we've... and so we thought, well, okay, can we do that? So we were fortunate, we reached out to Roche, which is another big pharmaceutical company, and said, through colleagues, through the MS experts that we had on the panel, and said, look, we've got this model we built, which we think is picking up really interesting kind of classifications and progressions in MS. Do you have data that we could validate it on? And Roche said yes. So some of our team went over to Switzerland, to Roche, to run our models internally within Roche on their data. So this was data that we'd hadn't seen before, hadn't been involved in any of the kind of the cross-validation. And before we went, we did a predefined criteria on how we would assess it. So we didn't want to go over, run the model and then try and, You have to be really careful, of course, in retrospective kind of analysis. So we predefined a number of criteria that we wanted to say, well, if we're going to go and fit the model on external validation data, we want to re-identify the MS dimensions, which are those 4 factors that came out from the sparse factor analysis. We want to rediscover the metastates that we had, these early mild evolving. And we wanted this particular thing, this bottleneck that we thought was really interesting of the relapse and the asymptomatic, which says you only get to the severe states by passing through these 2 intermediate states. So we went to Roche. We had data on like 2,000, just over 2,000 patients from 3 trials. And the model effectively matched what we saw. Not exactly, but subject to kind of sample variability that you would expect that we saw. We did a second external validation, which was we identified a large observational study. This is non-randomized, called MS Path. And we contacted MS Path and got hold of their data, which is about 2,000 people that we hadn't seen before. And the headline is that, again, the model replicated. And again, what we saw was this kind of bottleneck in the transient states. I think we had that in here, yeah. So we found, again, this fact that going from early to late, you pass through these 2 intermediate states. So what does this mean for practical implication for managing the disease? Well, the first thing is that actually getting hold of brain imaging is really important, and is missing in the traditional kind of classification. Another thing I just would kind of highlight is it might be for the practical management sufficient to consider just the two ends, the early mild evolving and the advanced. Because the transient stage you're not actually kind of in for particularly very long time, although you do pass through it. The other thing that we saw is that the traditional classifications do not map very well onto our states. And that has really important implications for developing treatments. Because it looks like the traditional classifications are not really capturing the heterogeneity. Because ours is purely data-driven, we suspect that it's capturing more of the underlying kind of disease biology. So then there's something very interesting we think about. How can we now explore treatments that target these underlying states and hopefully between the transition probabilities between those? So just to conclude, so the left-hand column is where we started from, the clinical phenotypes of MS, which are based on kind of two fairly kind of simple characteristics. People have talked about modifiers of them, but in a qualitative sense. And there were three main classes. What our data and modeling suggests is that there are 4 latent dimensions in the observable space. One that captures physical disability, one around brain damage, reserve capacity. Relapse sits on its own as a special, unique factor. And there's this interesting asymptomatic disease activity that you would only pick up through brain imaging. There's no modifiers because it's a data-driven model, so it's a dynamic model intrinsically. And we have this idea of a disease continuum where you move within states within early MS and then pass through these kind of transient states, either through a relapse state or through an asymptomatic state before you go to evolved. We see no distinction between the previous secondary progressive and primary progressive MS classifications. Currently, the disease-modifying therapies are effective in keeping you in that early stage, but show little kind of in terms of effect on the transitions afterwards. And we think the model allows you to better prognosticate on individuals because we've got a probabilistic trajectory that we can run for individuals. I'd like to thank everybody on the kind of more statistical side in Oxford, collaborators at Novartis, Roche, whose name I've misspelled there, who were very kind to allow us into their system to check our models, and a group of MS experts. Thank you very much.
Thank you very much for an inspiring talk. As usual, we're going to get questions. We'll do on that side of the room. Get close to Ryan and he'll let you ask the questions. I think I'm going to start with a quick one, although it's a bit of an elephant ask to change AI. In both of your works, I would say you are doing probabilistic machine learning. The conference called Machine Learning for Healthcare. So problems in healthcare with a probabilistic machine learning approach versus maybe more advanced AI, LLM tools? Is it a problem-dependent issue? Shall we just move on and call everything AI and Is our life easier that way? I don't know, just to start a conversation going. What are your thoughts?
Okay, first, I'm not sure if I would call the LLM models more advanced, but I think there are multiple dimensions. So I think you should always use the model that is best suited for your problem, right? And as you saw, many of my projects are in pediatrics, where data size is small. And just train a model from scratch would not be possible. So we often have very tiny data sets, so then just training would not, this was just not feasible. And also what I mentioned is that often my collaborators would like to have some notion of interpretability, and also, yeah, this is then for sure not given. But yeah, I give over to you, and then
yeah,
you can continue.
I mean, I would agree. I think it's getting more and more blurred. I think of the machine learning as more kind of like engineering solutions. So this is very much we wanted to engineer. And for us, we wanted to use simple models because we wanted to understand, we wanted to get interpretable results and build up the complexity, I would say. But starting from the simplest possible models that we could fit. And so the other thing which is really important is application driven. So there are many, we've heard amazing talks using large language models and neural transformer architectures, and they're really warranted, but it's kind of application driven. Yeah.
Okay, thanks for your thoughts on that. I guess we'll open the floor with the first question.
Thank you, both of you. Beautiful talks. I have a question actually for Dr. Julia Vaught. I really like the echocardiogram. That was for pediatric echocardiograms, right? So I just had a question. When you're dealing with ultrasounds, there's a lot of reflection, refraction, aliasing, and artifacts that can be captured in the images. So did you have like a pre-filtering stage where you removed images that had these things, or did you classify these as like, was there ever like, how you have the concepts? Was there like concepts for like, these are things to avoid, or like these are like, gonna corrupt the interpretation?
So for the ultrasound, images of the heart, so the heart is a very defined region, right? So what we always did is we cropped it in the size of the heart, so that it's always the same size, and we did some pre-processing, like also augmentations and adding noise and so on, that we take care of artifacts. And then these concepts are predefined, and they will always be in this region. But what we realized is that often the model, so the first versions of the model, found some potential defects actually at the boundary of this cone, right? So then in the next versions we made sure that we define a model that is circular and just defines this inner region to make sure, because we know at the boundary of the cone there will be no artifacts, but this is where the color changes somehow, right? And this was somehow captured. But yes, and so far we only did this in one hospital, so we have only one type of ultrasound machine, right? So I think if we change the ultrasound machine, we again need to make sure that we pre-process this in a right way to make sure we're not having some weird artifacts that we take into account.
Thank you.
Thank you.
I have a question for Professor Holmes. I really like the model you built, so my paper is very similar to yours. And my question is, how easy it is how is it very tough to use the model you built for other diseases? Because it seems the model you built is very specific to MS. If other researchers or clinicians want to use the model for other diseases, how difficult it is?
Well, at one level, it's very general. So, as in probabilistic factor analysis models driven through hidden Markov models. That's a general technique. So I think what we did is kind of piece it together. So we did the sparse factor analysis because we knew that a lot of the kind of multivariate measurements were highly correlated. And so you need to be careful if you get very highly correlated variables that they don't kind of dominate. So you imagine you could have 1,000 highly correlated variables, yeah, and then like 2 uncorrelated ones which are really important, and then the 1,000 correlated ones can kind of dominate. But if you put a factor analysis model, it can kind of pick that out. But the use of a kind of a factor analysis as a kind of generative model off the back of an HMM, of a hidden Markov model, that's a pretty broad class of models. So, I mean, whilst you wouldn't use the load-ins and the weights from what we've done, the general approach could be applied for disease progression or patient trajectory model.
Okay, thank you. Another question is, so I saw you only have eight biomarkers, but what if a disease have, as you said, 1,000 biomarkers? Is the model still applicable here or not?
Yeah, it is. You'd need enough data to be able to kind of identify, but the kind of sparse factor analysis model is pretty scalable. So I wouldn't be worried if you had 1,000 measurements.
But what about the runtime? So is the computational cost?
It would depend on what compute you've got, how much data you've got. Yeah.
Thank you.
It's pretty quick though.
Hi. I also have a question for Dr. Holmes. So if I understand your model correctly, you're kind of basing it on the assumption that you have these different stages of progression of the disease, that basically everyone has a certain probability of transitioning into. Have you looked into kind of breaking that assumption and saying, okay, I'm going to try to distinguish different maybe subtypes, either by patient or by disease subtype, that will tell you or allow you to predict either the full kind of path or at least differential, like different probabilities of transition depending on, you know, things that you may know from the beginning of the disease progression.
Yeah. So I think that, so the question is that the way the hidden Markov model is that if you're in state, say 3, say this table is in state 3, you all have kind of equal probability of jumping into this table, or you all have. So what you can do is you can try and condition and do conditional state transitions, which says, well, if you're all sitting around table 3, but I know something about you, then maybe I alter your transition states. So then on those arrows, then they become conditional probabilities of moving. It's a really interesting idea. We didn't do that.
Thank you so much to both speakers. My question is for Dr. Holmes. So I was wondering, how were you able to sort of like determine that optimal state space dimensionality and deal with the model selection? And then the second one is, what are some of the advantages of using Bayesian statistics, Bayesian optimization, and hidden Markov models as compared to just, you know, taking all the brain images and fitting that into a large language model?
So the first question was, how do we choose the dimensionality of the number of states? So the 8 states in the hidden Markov model, we chose using something called the Bayesian information criteria. The Bayesian information criteria looks at the likelihood of the data. So there's a fidelity to the data. How well do you kind of predict the data? But then what we know is you can't just use that on its own, because the more complex models, you add you can keep adding parameters in, keep adding states. Of course, you're going to do a better prediction on the data that you've got. So it has a penalty in there, the BIC. So then you have this kind of regularization. So you've got a fit to the data plus a penalty on the number of parameters, which is also a function of it's like P log n. So it's like you penalize the number of parameters times the logarithm of the number of data points. And then we fit models of different dimensionality. So we fit the model with like 4 states, 5 states, 6 states. We went up to like 10 states, and what happens is you get this sharp elbow where it drops, the loss function drops to when we've got 8 states, and then it goes a bit flat. And what happens is when you go to 9 states, 10 states, you take one of those tables and you break it in 2. So you take a state and you subdivide it, but there wasn't enough evidence to really suggest. So it was a bit heuristic, but when we looked at that loss function curve, we said, we'll go for 8. And I've forgotten the second part of the question. But
The second question was the advantages of Bayesian optimization and hidden mathematical models over training just a large language model and feeding then all the brain images.
So this is an underlying generative model. So we wanted to do a joint probability on observables. And I think if you want to build a joint probabilistic model on observables, there are very strong reasons why Bayesian is an advantage. That said, we had to do a lot of computational shortcuts. So we did things people might know, Laplace approximations. We used a lot of kind of EM algorithms, expectation maximization algorithms in there. So it's not kind of fully Bayesian, but we tried to adhere to the kind of joint probability models of Bayesian inference.
My question is also for Chris Holmes. I'm really impressed by how your work is kind of a success story for the classical probabilistic machine learning paradigm in a very useful setting. I think I'm very influenced by the spirit of the age, but upon seeing a problem like that, my first instinct would have been to say, oh, MRI, I need a deep neural network somewhere. I could make it Bayesian somehow, but in the features, but I put deep neural network there. I wouldn't do a factor analysis because would I be so lucky that things would be linear? I'd throw a deep neural network in there too, and then I'd kind of throw everything I had at it, try to maximize like quote unquote accuracy, and then try to do interpretability post hoc. So I'm really impressed that you stuck to keeping things simple and you got a fantastic result. Do you have comments on, do you think that approach works more than we think it might, and that we might be too quick to reach for deep neural networks in settings where we want to understand what's happening?
Well, first caveat, we started this work probably 5 years ago. And what would happen if we started today? I think we would still do this as a baseline. Yeah, because I think if you dive in with, say, deep generative models, you wouldn't have picked out that there's actually quite a simple kind of latent structure. Now, whether we can improve the resolution and the interpretation of this using more modern deep learning methods, that's to be seen. We're currently building diffusion models on the brain imaging, which would allow us to, rather than take summary statistics that we model through the latent factors, actually build deep generative models. Whether we would get them to scale around 200,000, we've got 200,000 brain images on 35,000 patients. That would be a considerable kind of computational resource that you would need to put together on that. That said, I think it would be really interesting to try that stuff.
Thank you for the fantastic talk. I have one question for each of you. So first, Professor Watt, I'm super interested in the interpretability of deep learning models. But as you said, the explainability post hoc is usually not unreliable, and the intrinsically interpretable AI model are super difficult, and they are black box in nature. And I hear that some people think the inherent interpretability is the way to go for high-stake decision making. There are also other people saying the performance kind of origins from the black box nature, and they argue that we still don't fully understand how Tylenol works. Maybe as long as we use rigorous trials and make sure the performance is good enough, we don't need to bother with the mechanistic interpretability. I'm wondering your perspective on whether intrinsic interpretability is the way to go.
But I would not say it should be either interpretable or explainable. It really always depends on the problem you look at. So, and you should, I think, always take the easiest model possible and not take complex models if an easier model works. So we've seen here that if you have a model that is sparse, and sparsity is one of the most intrinsic interpretable models that you see exactly which features are picked. If that works, it's great. But if you really need the black box because the classical models are not powerful enough and you need really the large deep neural networks, then you need to go for the post-hoc explanation if you really need the explanation. I mean, not always explanations are, in not all applications, explanations are needed or necessary, but if you really need them, I would say, I would not limit myself first on which model to choose, but say which model is the best for my application. And if it's an interpretable one, great, but if you really need, for some reasons, to have the larger models that are more complex, where you just really don't know what's going on, and you need an explainability component, then you try to later on see what is happening there. So I would not say one is better than the other. It's really application dependent.
Thank you. The second question is for Professor Holmes. I'm really impressed by your model, and I'm just wondering, in your external validation, why still fitting the model first, but not just take the outside data and classify them into your identified states using your development cohort and see whether the probability trajectory or transition probability changes.
Yeah. So the first part to that question was, and in the title of the talk is around, and in the paper is around reclassification. So what we see is one of the big kind of take-home messages, or one of the big insights that we've got, is that we think we could argue that people should be thinking about these 4 states in particular. Well, eight underlying states we see, but we can cluster them into 4. And so that was the primary thing that we wanted to replicate. What's the evidence for the 4 states? So when we went over to Roche and we got the data, we were interested to kind of run in the model, run in the things like our characterization of the states, and seeing if it matched onto the ones that we found within the Novartis data, and it did. So we could have just taken the model structure and looked at the different trajectories. So the actual the transition probabilities were different, but you would expect that because you have a different population, because there were different clinical trials. So I think one of the states, one of the 3 original kind of conventional classes was missing in the Roche data. So we were expecting that the transition probabilities would be different between states. But we were hoping, and fortunately it did, is that the overall structure of the latent states replicated, which it did.
Thank you very much.
Hi, yeah, thank you both for the great talks. My question is for Dr. Vogt. My first part of the question was just asked. I was curious about your general ideas about interpretable, explainable, but instead I'll ask maybe a little more detailed question. I thought that on the echocardiogram project, the way that you use the reconstruction of the healthy heart in comparison to the actual image was really lovely and an intuitive way to see where the differences are. a lot of the time people might just have settled for a post hoc explanation like GradCam or something like that, which would probably be a lot fuzzier and harder to interpret. I'm just curious if, behind the scenes, if you contemplated using one or the other, if there was any interplay between maybe what the clinician thought was more attractive.
So there was a lot of back and forth with the clinicians, what is actually usable for them, and we tried many different models, and in the end we used the one that, in our feedback loops, they said is actually usable and feasible for them. Because what we want to do is we want to, in the end, bring this into the ultrasound machine so that in real time they see this. And this also needs to be something that is, like, for them intuitive and also somehow feasible to put into these machines. And this is also where we need to now to talk to the ultrasound provider, what can be done and what is feasible. And this is a complete different area, but yeah. So this post-hoc explanation was something that they really wanted to have. And I mean, which model in the end for the clinician, it was really just what is visibly the easiest for them to see and how can we show where it is, but which model they didn't really care too much.
It seems there are no more questions and we are almost at 3:30, so I guess we'll leave it here.
Thank
a lot
you.
for the talk.
Thank you.
So right now, if you want to leave, you're free to go, but MLHC has this, I don't know how to describe it, this habit of actually, well, there's going to be a quick announcement, but basically we have a habit of coming up here, the program chairs, and listening to the feedback that you have about the whole MLHC experience. There's also a question about looking forward, whether you are in agreement or not of maybe switching the days from Thursday, Friday, Saturday to Wednesday, Thursday, Friday. So Kai is going to do a couple of announcements, and after that, we're here to take notes and take your feedback. It can be positive, it can be negative, and things to improve for future years. So, yeah.
Just a quick shout out to RHCML. Pratik Gajane, he reached out to us and wanted to basically ask if people from MLHC would be interested in going to their workshop, their conference in September in Portugal. It's part and within the entire ECML convention. So if you want to take a quick QR code camera and get the website, and they focus on fairness, explainability, safety, and healthcare AI. A lot of similar topics, but more on like fairness and safety, essentially. So just a quick shout out to RHCML. And if you want to go, please take this and register. It's in the September. And now we'll begin our feedback session, okay?